just leave it here and then you can, okay, this is probably easier. Hello? Okay, we're ready. Good morning, I'm Danielle Stevens. I'm from DCOM 2013. I'll be moderating today. So first, a couple of housekeeping items. This is just a reminder that virtual participants are set to mute. If you have a question, please type it into the Q&A box and we will address it after the speaker finishes. If time does not permit, we will collect the answers from the speakers and distribute them to all registrants. All presentations will be available to view on demand online for 1 month following the conference. Attestation forms needed to claim CME credit may be completed by attendees on Sunday at the end of the conference. These forms will be distributed to in-person attendees and are available online for virtual attendees. PDFs of today's presentation are available at LMU-live.com, and disclosures for all of our speakers are available for inspection at the office of the LMU-DCOM Director of Alumni Services. So now I'm going to introduce our first speaker. Dr. Daniel Carr completed his medical education at LMU-DCOM in 2012. He then completed his neurosurgical residency at Providence Hospital, Michigan State University in Metro Detroit in 2018. After residency, Dr. Carr pursued interest in spinal surgery during a complex, minimally invasive, and endoscopic spine fellowship at Harborview Medical Center, University of Washington in Seattle, Washington. Dr. Carr is board certified by the American Board of Osteopathic Surgeons, neurosurgery specialty. His passions in medicine include graduate medical education, researching medical literature, and optimizing patient outcomes. He currently serves as core faculty at Ascension Providence Neurological Surgery Residency. He is also the chief of neurosurgery at Trinity Health Livonia Hospital. Please help me welcome Dr. Carr.
Forward and back. Let's see. I just got my own computer for the notes. Can you guys hear me okay? I'm surprised to see so many people at 7 a.m. Normally the neurosurgery conferences that start at 7 have 1 or 2 people in the audience at 7. So that's a testament to all of you guys. How do I go forward here? This is laser pointer. Oh, the big green button. All right, so I do have one disclosure. I consult for Medtronic for spine, but that's not relevant to this topic. And I do want to say it's been a long time since I've been in Tennessee, in the southeast area in Tennessee, and it's just as beautiful. I took the drive from Knoxville down here, and I was just kind of blown away again, similar to the first time I drove to Harrogate and Cumberland Gap. And it really makes me miss this area because where I live in Michigan is super flat. And the rolling hills and the beautiful nature here is just amazing, and I'm kind of jealous of you guys for living in the area. So my talk today is on a pretty common problem that I think is going to become more problem over the coming years as patients live longer and longer. And this problem is normal pressure hydrocephalus. So we want to identify the key clinical presentation of normal pressure hydrocephalus, understand how it's worked up, what the differential diagnosis is of that disease, and then learn about what the surgical treatments are for NPH and the outcomes that we achieve after surgery. So we'll go over some of the history, epidemiology, clinical presentation, pathophysiology, radiographic features, workup, and surgical management. So we'll start with the history. This gentleman on the right is Walter Dandy, largely considered one of the founders of modern neurosurgery, along with Harvey Cushing, whom everybody's heard of. Walter Dandy did most of his work in pediatrics and around hydrocephalus in Johns Hopkins in the early 1910s and 1920s. And he first classified the basic definition of hydrocephalus as obstructive or communicating. And hydrocephalus, as we know, is essentially translated into water in the head. But we think of hydrocephalus nowadays as an accumulation of cerebrospinal fluid in the brain causing pressure that can then cause clinical changes. 2 additional types of hydrocephalus are hypersecretory or normal pressure hydrocephalus, which were added later in the mid-1900s. And the basic definition of obstructive versus communicating is just how it sounds. An obstructive pathology is something that obstructs the flow of spinal fluid through the brain. The natural spinal fluid would obviously be from the lateral ventricles to the third and fourth ventricle and then to the subarachnoid space around the brain. And if you block that pathway within the brain, we would consider that obstructive hydrocephalus. Common obstructive hydrocephalases are known as aqueductal stenosis or tumors of the brain that block that pathway. Communicating is a term that's more for a hydrocephalus that would occur after something that's blocked the arachnoid granulations or uptake of the CSF back into the venous system. So that can occur after things like meningitis. Hypersecretory is a really niche category that really is only seen in tumors that overproduce spinal fluid. Can be seen in some carcinomas, but more likely the choroid plexus papillomas. And then normal pressure hydrocephalus, which we'll talk about. So what is the overall incidence and prevalence of hydrocephalus? And it follows kind of a bimodal pattern. The hydrocephalus we think of and see most commonly is in pediatric population. You can see in the pediatric population that the incidence here is 88 per 100,000. And then in the adult population, it sort of continues to rise as you become over 65 or over 80 years old to over 400 per 100,000. So even when we think of pediatrics being the most common hydrocephalus when we think about it, actually patients that are elderly over 80 do have a prevalence that is a bit higher. And so this is just a generic, it doesn't represent the actual hydrocephalus pattern, but this is just a generic bimodal distribution that we see in this type of problem. So when we talk specifically about normal pressure hydrocephalus, the incidence is about 5.5 per 100,000, prevalence being 21.9 per 100,000. And you can see down here that one paper lists a 5.9% prevalence of normal pressure hydrocephalus in patients greater than 80 years old, which is quite high for a neurologic condition in that population, a neurologic condition that can be treated effectively with surgery, and men and women are equal. So I'm not sure, my animation must not have come through, but this is the initial paper by Hakim and Adams in the New England Journal in 1965. They had one paper prior to that, but this paper shows that their initial thoughts on 3 patients who had primarily conditions of dementia or psychomotor issues, that then they did this thing called a pneumoencephalogram, shown here on the left side, which is quite a barbaric procedure where they actually take out spinal fluid, inject air, turn you around, and then take x-rays of your brain. And you can see the size of the ventricles in the brain is quite large. Normally you'd see them a lot smaller here. This is a procedure we don't do anymore because if you actually read through this whole paper, these 3 patients were in the hospital for, I think, like 30, 40, 50 days each with ups and downs in their clinical course. But this shows the clinical picture, chronic symptomatic occult hydrocephalus, meaning over time developing, not acutely developing. And the principal topic is this disabling dementia with psychomotor issues. And this is kind of what we see today. I mean, these 3 specific cases were a little bit more advanced than we would see now, but this pathology is initially described similar to the way we find it now. So my daughter made me put this in here, the Uno card. She loves playing Uno. But this represents what we would term as a potentially reversible cause of dementia, this normal pressure hydrocephalus. And we know a lot of dementias, Alzheimer's dementia, Lewy body dementia. Those are not reversible. They may be slowed with medications, but they're not reversible. But this normal pressure hydrocephalus represents a possible intervention point for patients prior to them becoming severely demented, where we can potentially increase or improve their memory, their attention. And so some of the other reversible dementias, which I have on the next slide, are depression, anxiety, metabolic issues, medication side effects, and psychiatric issues. So here's a list from a good paper that lists a lot of different potentially reversible causes of dementia. Some of these are more on the line of a delirium, an inpatient delirium, but you can see a lot of the common infections we learn about in medical school, like meningitis and syphilis, late syphilis. You can see some tumors or abscesses or subdural hematomas. Those would cause delirium. But really, the kind of the heavy hitters that I think about when I think about reversible dementia are normal pressure hydrocephalus, the thyroid issues, and then any drugs and toxins that may be causing reversible dementia. So most of the time, we're treating what I would term idiopathic normal pressure hydrocephalus, which is by and large the most common subset of normal pressure hydrocephalus. But it's important to know that normal pressure hydrocephalus as an etiology can be created by other pathologies. And these we would term as secondary normal pressure hydrocephalus. And the pathophysiology, which we'll go over later, is very similar to the pathophysiology that you would see in some of the meningitis I talked about earlier, the hydrocephalus from getting meningitis, or the hydrocephalus from blocking the uptake of CSF from hemorrhages or traumas. Even some postoperative cases where the patient does well and then develops some scarring, and the reabsorption of spinal fluid is delayed and causes a delayed hydrocephalus. Radiation as well can cause a delayed hydrocephalus. And then carcinomatous meningitis, which I think probably needs its own category. It doesn't produce as much of a normal pressure hydrocephalus as it does an increased pressure hydrocephalus, but I included it there for completeness. Typically, these patients with carcinomatous meningitis will have pretty increased pressures and can have significant visual problems as well. So this picture on the right is our classic Netter picture that you see in medical school. And you can see the classic triad, the Hakeem-Adams triad, which came out of that 1965 paper, primarily consists of three different key clinical things. Again, usually the patient is greater than 60 years old. But we start with a gait disturbance. We can develop dementia and urinary incontinence. The percentages of patients who have the complete triad is probably around 60%. Most of the time when you see normal pressure hydrocephalus, they're primarily presenting with gait disturbances or mild cognitive issues like forgetfulness or attention problems. Sometimes we get the urinary incontinence, but sometimes it's very hard to actually pin down what the incontinence is from, and some patients can have long-standing incontinence that's not related. But you can see in this picture on the right here, it shows the difference in the brain here, the larger ventricle size here on the right. And then I like how he included, this is after surgery. He includes all the worst parts of surgery, so getting a subdural hematoma or getting an infection, which we'll go over in the outcomes of surgery a little bit later. This is a nice book you could buy on Amazon if you want, and kind of how we were taught, wacky, wet, and wobbly. So the dementia, urinary incontinence, and gait disturbance. So what are some symptoms that when someone sees may lead you away from the normal pressure hydrocephalus diagnosis? Seizures, I think, is a big one. And obviously, I think with anything you're working up neurologically now, imaging is a huge part of workup. So you're going to be able to work through a lot of these things and make sure that patients haven't had strokes with lateralizing findings or any type of mass lesion with aphasias or prospagnosias. And hallucinations, you're going to want a neurology evaluation to make sure they don't have any Lewy body dementia. Hyperreflexia, you may be looking more for spinal pathology or spasticity. And headaches, these patients typically do not have headaches from what I've seen. Papilledema, which can be outlined here on this picture, is usually not seen as well because in this diagnosis is normal. So the pressure inside the cranium should be normal. And papilledema is seen with increased pressure in the brain, as we know. So what is it about the gait disturbance specifically? And the word that's normally used to describe the gait disturbance is this magnetic gait, which I've outlined here, or feeling glued to the floor. So when patients are walking, they're taking short steps, and it takes them a lot to get their foot off the ground. This actual magnetic gait, I think, is probably later in the course of normal pressure hydrocephalus. And typically the patients that I've operated on with normal pressure hydrocephalus have more of this short shuffling steps and a slow gait. And this is the symptom that I see most commonly improve after shunting. The next picture here, and I'm not sure if I can get this to play. Hopefully I can. Do you guys know how to play it in the back? Is there a way you can play it? I see him moving back there. So this is a YouTube clip of an old VHS that shows the classic magnetic gait of a patient. Can't play it? Okay, great. So that's a great fuzzy picture of this guy, and just imagine he's walking with his feet stuck to the ground. So typically they're going to be kind of a little bit shaky when they're walking, and it's going to take them a lot to get their foot off the floor, and then they'll move the next one like this, and then the next one like this. And this is another great fuzzy picture as well of another video, which we can't play. And these are both actually on YouTube. They're the kind of the top results of normal pressure hydrocephalus if you just type that in. But this one is quite dramatic, where you can see this guy doesn't have as much of that magnetic gait as he does just a slow gait, and he's just taking very, very small steps. They time him out, and it takes him 64 steps to complete like a 10-meter challenge. And then they shunt him, and right after the shunt, it takes him only about 30 steps to complete the same challenge. So this is the kind of picture that I typically see after a shunting procedure. So when we actually evaluate gait disturbance, a lot of my clinical decision does come on not only objective tests, so this timed up and go test or a straight walking test. Usually they'll use 10 meters. But obviously a lot of it comes from what does the patient and the patient's family feel improved after the test that we do. So if a patient has a procedure to drain spinal fluid and they subjectively get up and start walking around and they feel fantastic, then regardless of these objective tests, this timed up and go or the short distance straight walking test, that patient would be considered a surgical candidate. So I guess my point with this slide is it doesn't only matter what the physical therapist or what an official time test of the walking after a lumbar puncture. The outcome is objectively, but also matters a lot subjectively. So the patient's family is a huge part of decision making for surgery in my practice. So dementia, a very broad topic. Typically these normal pressure hydrocephalus patients will have a few key things: memory impairment, slowness of thought, and reduced attention. There's a problem with this diagnosis that a lot of these patients can also have concomitant Alzheimer's disease, and that's actually been proven with biopsies. So patients who were going to have a shunt placed had a small biopsy of the cortex, and some of those patients did have biopsy-proven Alzheimer's disease. So there is definitely a spectrum, and clinical judgment is needed for some patients with more advanced dementias to see if they would even be a candidate for any type of surgical procedure. Urinary incontinence, and typically the finding is this detrusor overactivity, and I won't be claimed to be a urologist and describe all the different incontinences, but typically the patients that I see come in with this more of an urge incontinence type picture where they feel they need to go to the bathroom, they have to go to the bathroom frequently, and when they need to go now. Occasionally that leads to incontinence, but occasionally it just leads to the increased frequency and urgency. So getting into the weeds a little bit about the spinal fluid and the pathophysiology of this disorder. So this is just a depiction of, as we all know, the production of spinal fluid is made with choroid plexus and the ependema lining the ventricular walls. And typically it's described as what we would say a mass flow theory, where most of the spinal fluid is produced in the lateral ventricles, it flows to the third ventricles and then the fourth ventricles. As we've researched this over the years, there's probably a lot more extra ventricular spinal fluid produced than we thought previously. However, this is again the typical medical school depiction of how spinal fluid is produced. And we have about 120 to 150 milliliters of spinal fluid in total in our subarachnoid space through the brain and the spine. And we turn that over about 4 times per day. So a patient will create 400 to 500 milliliters of new fluid and replace the old fluid. In patients with normal pressure hydrocephalus, they probably actually produce less spinal fluid per day at a rate of about 60% of the normal. And why that is kind of unknown. So how does this lead to, all my animations are gone. So that's not good. Well, I'll have to talk through this. Is there any way you can move these pictures or no? No? Oh, okay. That's interesting. All right, so this up here is a depiction of a typical pulsation wave if you put a catheter into the ventricle. So it follows a similar wave to what you would see in an arterial waveform. So the first bump is P1, which is the arterial pulsation. So the artery pulsates in the brain, the spinal fluid moves around the artery. The second is what we would call brain compliance, so the brain responds back from that pulsation outward, it comes back inward. And then the third is the dicrotic notch, or the closing of the aortic valve. And this is a normal ventricular waveform or spinal fluid waveform. As the patient breathes, you can see it over a longer time course. The actual pressure inside the brain will vary with respirations. And if you look down here, this is the thought process of why normal pressure hydrocephalus may actually expand the size of the ventricles. Because you would think if the pressure is normal inside the ventricular system, then the brain should not move at all. It should stay in the same size because it's the same pressure it's always been. But if the brain experiences temporary short increases in intracranial pressure, then that can over time expand the walls of the ventricle. So over many minutes you see this, we have the up and down normal waveform that we see here, but in minute 1 or 1.5 you've had a temporary increase in pressure that then goes down, and then over time another temporary increase in pressure that goes down. And this is one of the thought processes of why the ventricular walls may expand. So overall, in normal pressure hydrocephalus, again, the CSF production goes down, but the resistance to the spinal fluid being reabsorbed by the body goes up. So you have less spinal fluid being produced, but you have higher resistance to it leaving and being turned over. So this over time will create these pulsation waves that then expand the ventricles. Now, so now you have expanded ventricles inside the head. What does that actually do? One of the thought processes here under this picture is that this will actually slow the blood flow surrounding the ventricular walls and can cause some temporary or permanent ischemia to the neurons and cells that surround the ventricular walls. And this then leads to the findings that we typically see. Oh, there we go. How'd you do that? Okay. Yeah, there we go. We got it now. One of the older theories is that the fibers around the ventricular system are just mechanically stressed, but I think this theory down here is the predominant theory now. That blood flow around the ventricles is actually declining, and the metabolic clearance is then worse, and the neurons and cells around the ventricle then have this temporary dysfunction due to cerebral perfusion issues. That's how it's supposed to go. Does that mean I can play those videos now? Oh, okay. Let's look at the videos, because my depiction was not great of me just walking here. Nope. Oh, there we go. Yeah, so this is that patient prior to shunting. You see these kind of slow, short steps. I would speed through it, but I don't want to lose what we have, so. And this is what I commonly see, this slow, short steps. I take them out of the room, walk them in the hallway of my office, and this is the gait that I typically see. And then you'll see after here, his stride length is greatly improved. His ability to walk in a straight line is a little bit better, and his ability to turn is a little bit better. And this outcome is very achievable, in my opinion, for patients who are correctly diagnosed. Here we go. And this is the classic magnetic gait. This is the gait that we don't see that frequently, but you can see if you look down at his feet, he's holding onto the wall. It takes him a little bit of time to get up. He's really got short gait, and his feet are essentially not clearing the floor too much. And this represents his inability to make an easy turn. He's trying. So those are the videos. Perfect. Thank you for doing that. So what are the radiographic features that we look for? There's a group that published this NPH RAD scale, and they took all the papers previously and tried to come up with a good idea for radiologists of what we should look for. This Evans index is an index of the largest bifrontal dimension of the ventricles to the largest biparietal dimension of the skull. And a classic teaching is over 0.3, then that would indicate a hydrocephalic state. These other ones that we'll talk about are specific more to normal pressure hydrocephalus. They all kind of try to outline what's the most typical worst case scenario that definitely points to NPH, and they use these specific features. So narrow sulci at the vertex of the head. The sylvian fissures get enlarged. They can have focally enlarged random sulci throughout the brain, and the rest are more compressed at the vertex. The temporal horn dimension increases. That's kind of similar to the Evans ratio. The angle of the ventricles on a coronal cut becomes more acute, And then around the ventricles, you get these hypodensities, which are the thought process there is that slowing of clearance of, or cerebral blood flow around the ventricles. And these are some two conditions that we try to differentiate radiologically. Is it hydrocephalus just because there's a lack of brain or atrophy, which we term hydrocephalus ex vacuo, or is it a normal pressure hydrocephalus type picture? So if you have all these features, should you just get a shunt? And that's what this paper goes through. And they found that it does show some moderate discrimination for shunt response, but it can't be used on its own. So the takeaway is you need that clinical picture. You need a clinical picture that shows a Hakeem-Adams triad or some part of the triad in order to predict your shunt response a little bit better. And they found that some of the most significant findings for this were the Sylvian fissure dilation does predict shunt response, as well as the temporal horn diameters, which makes sense because they're on the previous RAD scale. This is a picture I included of a historical test we used to do. And in residency, my attendings used to say, if you want to shunt a patient, just order a radionuclide cisternogram because they're almost always positive. And the positivity of them is that when you inject this radionucleotide, this indium radionucleotide, you get reflux of the radionucleotide over time directly into the ventricles. A normal patient should have filling of the whole subarachnoid space over the convexity of the brain, as well as the subarachnoid space in the spinal canal. But the normal pressure hydrocephalus was thought to just be reflux into the ventricle. This is really not ordered anymore. It's not even in any of the new guidelines, but it is a historical thing that we used to do. So when you have a patient, how can we work this patient up and identify whether or not they're going to be a candidate for shunt surgery? So you've had the clinical diagnosis with your triad of symptoms of urinary incontinence, gait disturbance, and dementia. You've had a radiologic workup with a CT or MRI scan. Typically, you want an MRI scan. And then the next step is, okay, would they respond to a shunt? We can't do that alone with radiographic features, but we can add additional testing to see if they respond. So the most common is this TAP test. So a lumbar puncture where you draw 30 to 40 cc's of spinal fluid. And then you either subjectively or objectively measure their response to that with their gait. So you get them up and walk them about an hour later, or within 2 to 4 hours, or sometimes even within 24 hours, and see if they feel a difference in their walking, or the physical therapist that's there feels a difference in their walking. You also, just to be sure there's nothing crazy, send labs. Usually I send the basic labs, which are, glucose, cell count with differential, culture, protein, but also sometimes I send some odd labs like cryptococcus. I had one patient who actually had, in residency, had cryptococcus meningitis, insidious over time, and he presented exactly like a normal pressure hydrocephalus. He responded to the TAP, he had the triad, he got a shunt, he got better, but then he got worse again, and eventually it was diagnosed as cryptococcus meningitis. So really, really high variability amongst studies of the sensitivity and specificity, as well as the positive predictive value. I have a nice graph a little bit later about the specific ones from the American Academy of Neurology. The other opportunity for draining spinal fluid and seeing the response is not just doing it one time. So this is a one-time thing. You go in, the radiologist takes off 30, 40 cc's, or the neurologist. You get them up, you walk them around, you send them home, you have a subjective journal or diary of how they do over time. But the secondary ideas, instead of doing that one time, let's do it over a longer period of time. Let's do it in 5 to 7 days. And that would be this extended lumbar drainage. This is where you actually admit a patient to the hospital, you place a catheter into the intrathecal space, and you drain spinal fluid at about 5 to 6, maybe 7 cc's per hour. and you see how over time their response is, and you can measure them over many days in the hospital. This is kind of hard to do nowadays because it's hard to get a patient admitted for this. And also there's a lot more complication and risk with extended lumbar drainage, such as subdural hematomas, infections. So you can see that one study quoted almost a 2 to 4% risk of meningitis and risk of death with this of 0.2%. The risk of death with a lumbar puncture is less than 0.1%. This is the final way to measure or test spinal fluid to see if people have normal pressure hydrocephalus, which is this outflow resistance test. This is largely done in a laboratory setting. In the US, it's really not done at all. But you inject fluid and then you measure the resistance to outflow, similar to the actual pathophysiology of what we think. But this greater than 18 is considered specific and sensitive for normal pressure hydrocephalus. Again, this is not, I've never done this in practice or residency. This is not done really in the US almost at all. So now that we've done our workup with our TAP test or extended lumbar drainage, we've got our radiology and we've got our clinical features. How do we manage this? And there's several different guidelines. The neurology released the guidelines regarding response to shunting in 2015, which we'll go over. This is the guideline that's really the most comprehensive, the Japanese guideline, and it was recently on its third edition in 2021. So this is that 2021 a guideline from the Japanese Society of Normal Pressure Hydrocephalus. And this outlines, now that you've gotten your whole clinical picture, what is the, how do we label this? So I like how we label it. The first is it's possibly normal pressure hydrocephalus. You have one symptom. The symptoms aren't explained by any of the other neurologic condition, and there's ventricular dilation. So now next is there's probable normal pressure hydrocephalus. So it meets this, then you actually do the test, and the test shows that the CSF pressure is not above normal, and that you have the normal, the imaging findings that we went through before. And then definite, which is the best for the surgeons, is that you had a shunt and it worked. So this is the paper I was talking about with the American Academy of Neurology. This shows, with those tests that we talked about earlier, what is their likelihood of producing a response to shunting. And the extended lumbar drainage and TAP test are really the ones we want to focus on here. They show that they have kind of a moderate specificity, but a pretty high sensitivity for normal pressure hydrocephalus response to shunting. These other ones are studies of CSF outflow resistance, also another CSF pulsation type study that's not done that commonly, and this one has to do with the MRI appearance of the aqueduct. And this is kind of the easiest graphical depiction. One of the problems with outcomes with shunting is, how do you define an outcome with shunting? Did they just get better with their gait? Did they get better with their cognition? Did they get better with their urinary incontinence? How do you measure it? Is it solely subjective? Is there an objective finding? And I don't think that's really elucidated yet. So with these patients who have all are part of the clinical trial, plus the ventriculomegaly, if you just take this, 82% respond to shunts. If you add a test to measure outflow resistance, extended lumbar drainage, or a TAP test, you can get higher results. So what actually is a shunt? Typically the most common shunt is called a ventriculoperitoneal shunt. We place a catheter into the ventricle of the brain, whether that be from the parietal approach or the frontal approach, and then we tunnel a silastic tube to a valve and tunnel the silastic tube into the peritoneal cavity. Most neurosurgeons will do this on their own. Occasionally they'll add a general surgeon for access to the peritoneal cavity. If this, and this is by far the most common procedure, the secondary ventricular shunting would be shunting directly into the atria. So instead of going into the peritoneum, you go into the atria. And then some of the more rare shunting procedures are shunting into the pleura, which almost universally will cause a pleural effusion, shunting into the gallbladder, which is extremely rare to be seen, and then shunting into the bladder, which is, again, I've never seen this or this. I've seen a ventriculopleural, ventriculoatrial, and ventriculoperitoneal type shunts. These are the valves that are used, and the valves consist of a couple different things. Number one, they consist of a reservoir. This is the thing that we can feel, that when we push down, actually, we can feel the response of this. So sometimes in notes, you may see the shunt pumps and refills, which means that it's CSF is coming out of that shunt and it's refilling with CSF from the ventricular system easily. The second is the actual valve mechanism, and this valve mechanism will control either the pressure or the flow of spinal fluid. Typically, we use programmable ones, which are controlled by a magnet, and this magnet can then change through different performance levels of a shunt or different settings of the shunt to increase or decrease the resistance to spinal fluid outflow. So in terms of the risks of shunting, the most common thing that I tell patients is the risk of infection is pretty low, but it's always going to be there. So if the wound were to open up or you were to have a peritoneal infection, the catheter can become infected and then infect the spinal fluid. So the risk of infection is not a short-term risk, it is also a long-term risk. And with the initial procedure of shunting, the most feared complication is a catastrophic bleed. We're only making a really small hole in the skull, and we're only seeing a tiny portion of the brain, but you're obviously passing about 10 centimeters of a catheter from the back approach or 6 to 7 centimeters from a frontal approach. So that catheter does have a lot of brain to transverse, and you can have, and I have seen this before where a patient did have a significant hemorrhagic complication from a shunt and actually passed away. So I tell my patients a 1% risk of catastrophic hemorrhage with a shunt. Overall, the complications are about 15 to 38%. And most of the time, again, the patient will do quite well from the shunt if you've worked them up properly. Depending on who you read, there's about a 60 to 80% good outcome, clinical outcome, which I typically measure as subjectively being happy with their improvement in gait. I typically will not do this type of surgery unless they've had the gait disturbance. I don't think that dementia alone or urinary incontinence alone is a good way to, or a good thing to treat with shunting. And those patients who don't respond oftentimes go on to have other concomitant neurologic disorders. So kind of in conclusion, I think I ended a little early, but remember the wet, wacky, and wobbly as the symptoms of the triad. Remember some of the imaging findings that we talked about. And then with these positive, consider referral to neurology and neurosurgery for that TAP test or a extended lumbar drainage. These are some of my friends from med school, some of our references. All right, any questions you guys have?
When you're looking at that or doing your TAP, do you ever do any studies of the fluid for tau protein or anything like that, or look at to see if that influences some of the issues surrounding dementia, or perhaps has there been any look at that?
Yeah, there has been. I didn't include that in this presentation, but there are a couple papers that show that there is an increase in tau protein in a lot of patients with normal pressure hydrocephalus. And that may be because some of them do have also probably concomitant Alzheimer's disease.
Second question, how do you judge when you need, make the judgment in terms of replacement of these shunts? Is it the changes in the symptoms, or how do you look at that going forward in terms of monitoring these shunts?
So there's, I think there's two questions there. Monitoring shunts, once I've implanted the shunt, I will typically get at least 2 CAT scans post-operatively well, there's one immediately post-operatively to make sure there's no bleeding or complication. But then 1 to 3 months after, I'll usually get a couple CAT scans to make sure that the valve setting has not decreased the ventricular size too much and caused any type of subdural hematoma. Long-term, let's say one year, 2 year, 3 years out, I primarily would look at the clinical symptoms. So if they have return of their gait disturbance, then that would lead us down the pathway of looking into the shunt. And looking into the shunt would be, typical, probably CAT scan again. With MRIs, anytime someone has a programmable shunt, you have to reset the valve. So typically I get a CT again to see if the ventricular size changed. A lot of patients with NPH, even with a shunt, the ventricular size doesn't change. Their clinical symptoms improve, but the ventricular size remains the same. So in that case, I would go largely based on clinical symptoms and proceed probably to tapping the shunt, so placing a needle into that reservoir. And that would be an easy way to draw off 30 or 40 cc's of fluid. And if in the following days from that, they did get a lot better, then it would go to exploration of the shunt. Disconnect it from the catheter that's in the brain, see if that's flowing, and then flow some CSF intraoperatively through the valve and distal catheter, and then just kind of replace what's needed.
How long after the shot would you see any cognitive improvement?
Let me repeat that for virtual. How long after the shunt would you see any cognitive improvement?
I think that most of the improvement I've seen is within the first 3 months, but sometimes it is delayed a couple weeks. So anywhere from, I would say, 1 week to 3 months.
Other questions?
Okay, thank you.
Thank you. Take a 10-minute break. Our next lecturer, Dr. Elizabeth Brewer, is a board-certified family medicine physician in Tulsa, Oklahoma. She graduated from LMU-DCOM in 2011 as a member of the inaugural class. Dr. Brewer has been practicing family medicine in the Tulsa area for 9 years. In 2022, she opened a solo direct primary care DPC clinic. In addition to running her DPC clinic, Dr. Brewer is currently an adjunct faculty member for Oklahoma State University College of Osteopathic Medicine and volunteers as a team physician for the local minor league hockey team. Please help me welcome Dr. Brewer.
Hi, everybody. Everybody can hear me okay? We good? Nope, I'm good with this. I'm not going to move. Okay, so we're going to take a little bit of a left turn away from normal pressure hydrocephalus, and we're going to talk a little bit about direct primary care. Does everybody in here know what direct primary care is? Kind of have somewhat of an idea? So this is one of those things that I've realized in the last couple years that, is kind of hit or miss. A lot of people are like, what's that? So we're going to talk about it today. I have no disclosures. No one pays me, not even myself currently, so we're good there. So we're just going to kind of go over direct primary care and direct specialty care, kind of talk about the differences of direct primary care and fee-for-service models. I'm also going to touch on value-based care, which is the newer model that we're seeing in offices currently. And I'm going to talk about just kind of the basics of starting a direct primary care practice. So the saying is, if you've seen one direct primary care office, you've seen one direct primary care office. They're kind of like snowflakes. Every single one is different. Every office is individualized and set up how the clinician wants it to be set up for themselves. You will not see two that are exactly alike. So the classic, what we consider the classic models of outpatient medicine, the first one is fee-for-service. You eat what you kill. The insurance companies pay for services rendered. The more patients you see, the more money you make. Your reimbursement is typically a percentage of the amount charged. If you've ever looked at an explanation of benefits for a patient or for yourself, or seen what you charge versus what the insurance company pays you, you take a significant cut. The newer model that came out around 2016 is value-based care. This was initially determined by CMS to improve quality of care and promote that quality of care rather than quantity of care. So they look at quality measures. Some of the big quality measures they look at are hospital readmission rates. They look at healthcare IT, which is what requires all of our clinics to have electronic medical records as well as patient portal access. You have to have a certain percentage of patients that are signed up for your patient portal to meet that measure. And then, of course, we have the quality measures such as diabetic numbers, blood pressure numbers, BMI, which we know our patients love when we talk to them about their BMI at every single visit. We see that all over social media. So your reimbursement is based on meeting those measures. However, with these value-based care, with the value-based care model, your reimbursement is also based on patient satisfaction scores, which is really great when you have to tell your patient that their BMI is elevated at every visit, but you also want to make them happy while you do it. So it's a fun little mix. However, value-based care, while they tried to improve quality over quantity, you still have to see a significant number of patients to get to the reimbursement rates that you want, because you're still getting a cut of the money. So what has this all led to? Well, these are a big part of physician burnout. I saw an article the other day that said that in 2022, 53% of physicians reported having an episode of burnout. That's a lot of doctors. In 2021, it was 63%, and I'm pretty sure we all know why. And the majority of those are either emergency medicine physicians or primary care physicians. So what do? How do we fix healthcare? How do we fix burnout? One of the best ways, well, the only way to fix our current healthcare system is to focus on the quadruple aim. So we want lower cost for healthcare services, a better patient experience, and for most of our patients, this means more time spent with them, letting them ask the questions that they need to ask, understanding their diagnoses and how we treat it. We also want better health outcomes, and of course, for us, one of the most important things is provider experience. Because if we're not having a good experience doing our job, we're going to get burned out faster, which is what happened to me. So let's talk about direct care models, which is a new spin on an old way of looking at medicine. This is somewhat the way medicine used to be prior to insurance companies getting involved in everything. This is one of the best ways to kind of focus on that quadruple aim of improving healthcare. So what is direct primary care? Direct primary care is a model where the patient pays the practice directly. There's no insurance company middleman. Typically, it's done by a monthly or annual fee. In my practice, we have currently a $75 monthly fee for our adult patients. We also offer acute visits for a one-time fee if they don't want to pay a monthly fee. There's no insurance billing. There is a clear understanding that this model is not health insurance. That is a very important distinction to make. I make sure every single one of my patients knows this is not health insurance. I usually recommend that they get health insurance in addition, and we talk about high deductible plans and other ways that they can do that care. And it also emphasizes and prioritizes the relationship between the patient and the physician. With direct primary care, you can go from seeing 30 patients in a day, like you would for fee-for-service or value-based care, to seeing 10 to 12 patients in a day and make the same or more money in the end. So direct specialty care is direct primary care, but for specialties. It's not a very difficult concept. And the Direct Specialty Care Alliance says that direct specialty care aims to remove the traditional insurance-based billing system, removing the burden of documenting extensively, coding, billing, accreditation, and contracting with the insurance companies. And I know that we all would love to do less documenting, less coding and billing, and less dealing with insurance companies. So this is kind of just a very basic direct primary care versus fee-for-service. So with direct primary care, you have a flat periodic fee that is transparent to the patient. The patients know before they walk in my door exactly what their fees are going to be. We talk to them beforehand if there are going to be any cost for labs or any extras, injectables, things like that that we may add on. They know before we do it, and they approve it before anything is handled. We have more time with patients. Most of my patient visits currently are anywhere from 30 minutes to an hour-long visit, especially for a first visit. You know, obviously, if somebody comes in for a cold or poison ivy, it's not going to take me 30 minutes to an hour, but they have that time available just in case they need to discuss something else while they're in the office as well. We have flexible scheduling. Our patients can get scheduled within 1 to 2 days, even as a new patient, which is unheard of most places currently. I know in Tulsa, Oklahoma, where I practice, as a new patient to see a family medicine or internal medicine doctor, I believe the wait is anywhere from 6 weeks to 4 months, which is a little bit on the crazy side. But I also understand how bogged down we all are. We also are able to offer discounted labs and imaging. So with your fee-for-service, obviously you have changing insurance reimbursement rates. Every year, CMS and the insurance companies come out with different rates of what they're actually going to reimburse you. And that's if they reimburse you on time. You have more appointments, less time with patients. And insurance approval is required for all testing and prescribing. I currently can order a CT chest for a patient. It will cost them $200, and it can be done same day or next day without any insurance approval for that. Whereas prior to this, when I was working in corporate medicine, it would take anywhere from 2 days to 2 weeks to get a patient approved for that, depending on their insurance. So, what does it take to get started with direct primary care? An idea, a giant leap of faith, and a lawyer. I personally know that I am the ultimate procrastinator, and so I had this idea for several years and decided that it was time for me to quit my job, because if I did not quit my job, I would continue to procrastinate and not do this. So I quit my job and then planned everything out. From my last day of work at my previous job until the day we opened, we were 3 months and 1 week that it took me to get everything set up and going. And then, of course, you need a lawyer, because we all need to have a lawyer in our back pocket. The lawyer will help you set up all of your business paperwork, help you set up bylaws, review all of your contracts and everything that you need for that. So some of the best resources that I have found to look into for getting started into a direct primary care or even direct specialty care clinic are the Direct Primary Care Alliance, Frontier DPC, and Atlas MD. They are all, DPC Alliance is an actual group. Frontier DPC and Atlas MD are both direct primary care clinics that are run by doctors that have done this for a significant amount of time and offer free resources to people who are interested. Ooh, wrong button. So, this is just an example. This is from the Atlas MD startup checklist. This is available to anyone who's interested. It's absolutely free. You can download it, or they have an online version. And this is just his basic checklist of how to go about setting up a direct primary care clinic. The most difficult part for me, honestly, was learning how to create my own website. I am not a technology person, but I did it, and I have been very proud of myself. The other hard part was coming up with a name for the clinic and a logo. And our clinic name is Infinity Direct Primary Care, which I came up with because it was an easy logo to make the infinity sign out of a stethoscope. It's how I did it. It's not anything brilliant. So the big thing is, come up with your basic plan. It doesn't have to be anything big. You're going to flesh it out as you go along. Start with your plan. Number 2 is where the lawyer comes in. You have to do incorporation bylaws, all of the stuff that they don't teach us in medical school that you have to learn about becoming a business owner. Create your brand, and then it gets into all of the big fun stuff. Again, you make this what you want it to be. My office is 1,300 square feet. It has 2 exam rooms, an office that I share with my medical assistant, a kitchen and a bathroom, and a waiting room. It's very simplistic. I know other people that have a 1-room office. Again, it can be anything you want it to be. Staffing and compliance. If you have even 1 employee, you have to do OSHA. That is, and workers' comp. Those are things that I learned this last year. I have 1 employee, and I pay workers' comp, and we do OSHA every year. Marketing. In the year of our Lord 2023, marketing has become very simple with social media. That is honestly the best way to market to patients, is through social media. I set up a Facebook page, an Instagram account. I have a TikTok account, but I'm too old to use it. So it just sits there. Maybe one of these days. But yeah, and so the majority of, I will attempt to post on my Facebook page maybe once or twice a week, and then patients will share it. And that honestly is how we've gotten the majority of our patients, is through word of mouth, through social media. So medications, down here at, oh, nope, wrong one. So down here at number 10. There are a lot of direct primary care offices that dispense their own medications in office. You can get very cheap medications through wholesalers, and if you get a dispensing license, you can sell meds to your patients, especially non-controlled meds. We're not going to talk about controlled meds. That's for later this morning. So I personally do not, and we'll talk about that in a minute, why I do not. But there are a lot of offices that will do their own dispensing in office. Labs and imaging, we'll talk about that too, and then start seeing patients. So using community resources. This was a big thing for me, and I think it's a big thing for a lot of direct primary care physicians, is figuring out what resources you have within your community. Where I practice, we have multiple local pharmacies. We actually have one pharmacy, it's called Gen Scripts, that they offer a dime a dose medications. So you can get your lisinopril or your hydrochlorothiazide for 10 cents a dose. So 100 pills for $10. You can get 400 pills for $20. The more you get, the more of a discount it is. They're a cash pay only pharmacy. We also have a cash pay compounding pharmacy in town. So we use a lot of those resources, which is why I personally don't dispense in office, because we have those resources at our fingertips. When I first started, one of the first things I did was I went around to all of the locally owned pharmacies in town, gave them a flyer, my cards, and talked to them about what we're doing. That has probably been our second largest referral source since doing that. Imaging centers. So we also went around to our local imaging, our local freestanding imaging centers, and talked to them about their cash pay pricing. They were all too happy to give us a sheet that had all of their cash pay pricing. I can get an MRI without contrast for $300. I can get an MRI plus an MRA for $450. If a patient went to a hospital to have that done using their insurance, if they haven't met their deductible, they're going to pay $3,000, $4,000 easily. So this is a great resource for those patients. Labs, we are contracted with a couple different labs locally. I was talking to Dr. Selk earlier. We can do a CBC for $2.50 and a CMP for $2.80. So we have an entire list of labs that we can do for these discounted prices, and then we just pass those discounts on to our patients. So we can also do a pap smear in our office for, I believe, $38 is the cost for the actual pathology read on that. We have, the other big thing is look into local resources for free or reduced cost preventative services. We are able to get patients set up for immunizations, especially childhood immunizations. We have an organization called the Oklahoma Caring Van that goes around, especially right before the school year starts, and does free immunizations for any child that needs them. We are also able to get any vaccines available to our patients through the local health department, whether or not they have insurance. If they don't have insurance, it's free to them. If they do have insurance, their insurance gets billed. Same thing with mammograms. We're able to get our patients not only screening mammograms, but also diagnostic mammograms for free or reduced costs if needed through local services. And then for those cash pay patients, we actually have this in Oklahoma. It's one of the only ones in the US, the Surgical Center of Oklahoma, that is a completely cash pay surgery center. And people come from all over the country to there to have surgery. All of their prices are transparent and listed on their website. It's very enlightening to see what these surgeries cost. And they have neurosurgeons, spine surgeons, gynecologic surgeons, ear, nose, and throat surgeons, general surgeons, just about any surgeon you can think of, they have on staff at the Surgical Center of Oklahoma. So one of the things that I didn't touch on earlier that I meant to was the topic of high deductible health plans. So with the direct care model, there tends to be a significant cost savings for the patient. If we think about what we as physicians and nurse practitioners and PAs pay for our own health insurance, think about how much that cost is for our patients, especially if they have a family. So even with a high deductible health plan, the average deductible is $2,300. The max deductible for those patients is $7,600 for an individual. For a family, it's $13,800. That's a lot of money that you have to pay before any of your health care is covered. So that's where DPC, that's another good place for direct primary care to step in, because we can offer more than 85% of those normal everyday healthcare services without charging their insurance and them having to pay these exorbitant prices. There's no deductible, no coinsurance, no claims, no insurance claims with direct primary care. So it works for you and it works for the patient. So statistics show that with a combination of direct primary care and a high deductible health plan, the patient can save anywhere from 20 to 30%, sometimes more, depending on how often they utilize your services. So that's kind of where we are. It's a growing field. I know that earlier this year, I helped a burnt-out emergency medicine physician start her own direct primary care office, and she's absolutely loving it. It's very much a community. Everyone works together and helps everyone out. There's no competition. It's really been a great thing, and I think it's something that, especially if you're feeling frustrated in your current job or just looking for something different, it's definitely something to look into and think about. So I think that's all I've got for now, and we will do questions after the next one. So thank you, guys.
Our next speaker is Dr. Danielle Harrell. She is currently an assistant medical examiner at the West Tennessee Regional Forensic Center, University of Tennessee Health Science Center in Memphis, Tennessee, where she has practiced independently since July 2020. Dr. Harrell is originally from Maynardville, Tennessee, and obtained her undergraduate degree in microbiology from the University of Tennessee, Knoxville in 2009. She received her Doctor of Osteopathic Medicine degree from LMU-DCOM in 2015 and completed anatomical and clinical pathology residency at the University of Florida, Shands Hospital in Gainesville, Florida in 2019. Dr. Harrell completed Forensic Pathology Fellowship in 2020 at the West Tennessee Regional Forensic Center. She is currently clinical faculty with the University of Tennessee Health Science Center and serves as the current physician leader of the Shelby County Elder Death Review. Please help me welcome Dr. Harrell.
Okay. Sure I can work this. Okay, so if we took a left turn from normal pressure hydrocephalus, I think we're going completely upside down with death certificates now. So I have no financial disclosures, and so the objectives. I'm going to move this because I can't quite see. Oh, yeah. I like to move. Okay, so in order to talk about COVID-19 and the death certificate, we're going to have to start with the death certificate, but we're going to have to go back a little further just in order to discuss the difference between a medical examiner and coroner, when to contact the medical examiner and coroner regarding a death certificate, or if, who should be responsible for a death certificate. My husband, who's speaking tomorrow, Dr. Williams, you could ask him. I could talk about that for about an hour or more, so I'm going to be brief today. We're going to go through how to properly complete a death certificate, and I mean the practicalities of it. Where does the information even go? And then towards the end, we'll discuss how do you properly include COVID-19 on a death certificate. And then we're going to review the FEMA COVID-19 funeral assistance. And that's important to make sure if you include that on a death certificate, COVID-19, will you do it in a way that will allow a family to apply for the funeral assistance program? So, medical examiner versus coroner. Medical examiners are physicians. Forensic pathologists are board-certified physicians in forensic pathology. Not all medical examiners are forensic pathologists. Coroners are elected officials. So that can be a sheriff, attorney, nurse, funeral home director, grocery store owner, kind of depends. But in certain areas, they could also be a physician or a forensic pathologist. You need to review your kind of state and local government statutes. For example, Tennessee is a medical examiner state. Florida is a medical examiner state. The way that system is set up is very different between Tennessee and Florida. For example, I'm thinking a lot of people here may practice in Tennessee. Your county of practice will have a medical examiner that is a physician. That is someone that you can reach out to if you have questions about death certificates, jurisdiction. When I say jurisdiction, you'll hear that word. That means who's responsible for the death certificate, essentially. Florida has districts. So you may have one medical examiner who is a forensic pathologist in that state that will cover multiple counties. For Tennessee, though, the medical examiner system, every county has a physician. That is your medical examiner. But per Tennessee state statute, if an autopsy that is considered a forensic autopsy, which we'll go over that, must be performed by a board-certified forensic pathologist. We do those by regions here. So, for example, I'm at the West Tennessee Regional Forensic Center. We cover about 13 counties that we do autopsies for that fall underneath the jurisdiction of the medical examiner's office. Those autopsies from other counties, I'm in Shelby County, Memphis, Tennessee, they must be ordered by the local medical examiner. I lay all that out because if you're in Tennessee and you have a death that you think should have been reported to the medical examiner due to trauma or their death was related to a prior event, making sure you know who your medical examiner is to know they're informed, because it's a complicated process of who tells the medical examiner in the first place about the death. And we'll go over that more. But for Tennessee, know who your county medical examiner is. They can be super helpful. So what I did, since every state and district can vary, I have pulled up the Tennessee state statute for medical examiner coroner jurisdiction. I say coroner just in case you're in a coroner state. So for us, the county medical examiner for the county in which the death occurred should be notified of any basically violent traumatic death or suspicious death. So what does that mean? So homicide, death at the hands of another. Suicide, a self-inflicted injury. We say violent, unnatural, motor vehicle collisions, suspected drug overdoses, or something that's not listed in the state statute, which I think is important to point out, is sudden, unexpected death of an individual. That means you have a patient who has no significant past medical history. They're young, typically young. Say you have a 35-year-old that you've seen one time, 2 times. They've come in just for their general physical, no complications, no diagnoses, they die. They die at home, they die in a hospital without a diagnosis. That typically falls underneath the jurisdiction of the medical examiner's office. The area where I see as a medical examiner deaths that are not reported to us is the temporal relationship of a death to an injury. So, say you're in the hospital, you're a hospitalist, primary care, doesn't matter. You were taking care of a patient who has a complication of a prior injury. Motor vehicle collision is what I gave here. Someone dies of pneumonia from being paraplegic, they had an MVC 15 years ago, you think it's related to that, you want to call us. Where we see it, I think the most is where someone's been in the hospital for a long period of time, paraplegia, quadriplegia, prior gunshot wounds, whether self-inflicted or someone else, those should come to the medical examiner's office. And that's because there's often criminal associations, especially with the motor vehicle collisions, gunshot wounds, stabbings, anything like that. They can kind of slip past us, and that can do a disservice to the decedent, the patient, their families, because it can make adjudication of a crime very difficult. So that's important to be aware of. So, when to sign a death certificate? This is I think, a hot topic that comes up sometimes, and many questions I get from my friends who sign death certificates that are not medical examiners. This is the question. So this comes from the Tennessee Department of Health, Office of Vital Statistics. Every state has an Office of Vital Statistics, which will be very helpful if you have questions as well. But this is pulled straight from that. It says, one of the responsibilities of a primary care physician is to provide death certification for his or her patients who die of natural diagnosed causes, even if the physician was not present at the time of death. This is specific to Tennessee, the next paragraph. It essentially says, if you've seen the patient in the 4 months leading up to death, you should sign the death certificate. Or you can call your county coroner medical examiner, here, medical examiner. But it does not limit to the 4 months. If you have haven't seen the patient in a year and you're pretty sure that their death is related to whatever cause that may be, you can still sign the death certificate. And then it doesn't have to be the primary care physician. That's another topic here, is any physician, cardiologist, oncologist, ER physician, which that's case dependent and that varies by location as well, practice location, I mean. But for the most part, physicians are the ones who are responsible for signing the death certificate. In the state of Tennessee, you must be a physician. So we get questions at our office regarding, say, you have someone in your practice who's mostly being seen by a nurse practitioner or a physician assistant, and you've never actually seen them as the physician. Per Tennessee state statute, the physician who is supervising should be responsible for the death certificate, even if they've never seen the patient. This idea of when to sign the death certificate, if you really feel strongly that you don't think you should be signing the death certificate, call the medical examiner's office. Our office fields calls all the time. We would much rather talk to someone and understand why they do not want to sign, because there have been cases where I agree. I'm like, you know what? I agree with you. Like, I think that this should probably be reviewed by the medical examiner. I say reviewed because we don't necessarily view every patient that comes in. We may just do a chart review. So if you don't sign the death certificate, it may be that myself or one of my colleagues will review your notes and see if we can make a determination on that. One important thought about this is, when death certificates get delayed, it's a very significant burden on families. Oftentimes, without a death certificate, even if it's a pending death certificate, families are not able to fulfill their life insurance policies. And you can see, I've had situations where it's been months before it makes it to my desk. And there are limitations to when, and depending on the policy, when someone can actually fulfill their policy. So you wait a year, some policies will not fill out, even if you ultimately sign the death certificate. So I'd be happy to talk more about that later. But this is where, this is it's like non-medical examiner cases. So when the death is reported to us and we say, no, we're not responsible for the death certificate. This is kind of a repeat of what I had above, that basically lays out more of the statute. So I won't go into any more detail. I just wanted the full statute to be present. Okay. So this is what a typical death certificate looks like. There's multiple pages, but this is where the business is what we say. So you have who's going to sign the death certificate. And if you see for ours, the top line, it says physician or medical examiner. If you click the box that says 26A physician, you will only be able to select this right here, natural manners of death. You can also do pending, but that doesn't typically happen. But if you want to select homicide, accident, suicide, or could not be determined, you need to be calling your medical examiner's office. The part that makes a huge difference too for the families is what we call them part 1 or part 2. Some states will say part A and part B. So part 1, that's where the main cause of death is going to go. Part 2, anything else that could have potentially contributed to the death will go in part 2. So I have it laid out more. I usually have this, I'm glad I didn't do it, an animation of dominoes falling, because I like to describe this to people as dominoes. So the first domino is the first insult that happens, okay? Then as each domino falls, you get to the top, which I know doesn't quite make sense. But at the bottom, the first thing that started the cascade that led to an individual's death should go at the bottom. Then you go to the next line. Then you go to the final part A, little a of part 1, is where the most immediate to their actual time of death. I know that's a lot of terminology, so I just did cases. Usually what I do, I just didn't have quite the time, I don't think. I usually will give a case and have everyone fill out like what they think the cause of death should have been and see how it compares to what I do. But so let's take a case. And there's more history here, I just brief. So you have a 40-year-old woman who comes in with a history of cirrhosis due to a long history of chronic alcoholism. She comes into the emergency room, has massive hematemesis. They are able to get her stabilized. They go in for an EGD, realize there's bleeding varices, but she ultimately dies. So that domino theory, starting with the bottom, chronic alcoholism is the first domino that started in this cascade for this woman. She ultimately developed hepatic cirrhosis, which led to esophageal varices, which ruptured, and then the upper gastrointestinal hemorrhage, the actual bleeding, is what was the most direct relation of mechanism to her death. Now, does it have to be perfect like this? No. I lay it out, it's preferable. And you think, okay, well, why can't I just say upper GI hemorrhage? Why can't I just say ruptured esophageal varices? Okay, you can. But I don't know if everyone's aware of what happens with the data that goes on a death certificate. So sure, it's a legal document. It gives families the cause of death. It certifies that this individual is indeed deceased. But funding for various conditions often can get pulled from epidemiological data, from vital statistics that is provided on these death certificates. So if you are constantly just putting, if everyone just said gastrointestinal hemorrhage, well, what kind? Where are we seeing the issues coming from? Do we need more research going into esophageal varices? It's a big deal, especially in cancer diagnoses, knowing what type of cancer, what was the complication of the cancer, and so forth. Infections, like knowing the true incidence of death from influenza. If everyone put ARDS and didn't put an etiology, we don't really know. We don't have this is one of the reasons is to have a centralized, statistical analysis of death. So the more specific you are, the better it is. I just gave another one to have a part 2 because there was no part 2 on the last one. So 17-year-old man comes in with a history of diabetes and coronary artery disease. He had had a stent placement 3 years prior, comes into the ED, chest pain, ST elevation, elevated troponins, goes into VFib, try to resuscitate him, and he dies. This is when we've had cases come to us and it's questionable about, maybe they didn't know who to send the DC to. I would look at this and I would say coronary artery atherosclerosis, acute myocardial infarct. We know that diabetes ties into cardiovascular disease, has the history. I'd put it in part B. Now, say I didn't have any of this other information. Say I get this 72-year-old man with a history of diabetes and coronary artery disease. He's had a stent. He's found deceased in his bed. No one's to sign the death certificate. You go, well, what would you say then, right? Like, you don't know. You don't have all this information. I'd probably say coronary artery disease and diabetes in part 1. It's okay to do that. It's also okay to say presumed, suspected. He would not get an autopsy had he come to our office. But you make your best guess based on what you know about the patient. Now, to switch it around, let's say I get the information from the primary care physician. He had a stent 3 years ago, but he's constantly been in and out of the hospital with complications of his diabetes. I may favor the diabetes and put the heart disease in Part B of the death certificate. Doesn't really matter in that circumstance. As long as you are making your best effort at what you know about the patient, that's kind of how we approach it at the ME's office, because we've never met most of the people that come in when we don't actually see the decedents themselves or do examination. So, okay, so COVID-19, that's what we really want to talk about with the death certificate. So now you know where to put things. How do you incorporate COVID-19? And this is going to definitely tie into the FEMA funeral assistance, so I want to keep that in mind. So you have a 45-year-old man. He was in ICU. He had ARDS due to COVID-19. He dies in the hospital. Be as specific as possible. You can say he started with a COVID-19 infection, he developed pneumonia, he got acute respiratory distress syndrome, that is his cause of death, you're done. In this case, you'll have not probably a lot of questions from FEMA if the family was to apply, but that's just straightforward. But keep this in mind for any infections. You know, you have MRSA, influenza, whatever it may be. It's important to include the actual infection on the death certificate if you know. I'm not going to go over the things not to put on a death certificate today, but that's how I would have signed that death certificate. So let's look at him in a different way. We're going to go back to the man who has the history of diabetes and coronary artery disease. We're going to say that he had that exact same situation. He came into the ER, he had chest pain, he's got the ST elevation, he's elevated troponins, goes into VFib. But did a COVID-19 when he got to the hospital and it was positive. Okay. So what do you do there? Well, you don't know, right? But we do know that COVID-19 is not a good thing to have if you have heart disease. We know that having underlying natural medical diseases, especially respiratory or cardiovascular diseases, can be exacerbated by COVID-19. In this circumstance, I have put COVID-19 in the second part of the death certificate. I think I can't disprove it. I think that it could certainly contribute, and that's the purpose of Part 2. Whatever is in Part 2, could it have had any effect on his death? And I think so. Now, this is me talking about the idea of a probable suspected. So you have the 45-year-old man we discussed earlier as well. This time, though, let's look at him saying that he's able to be weaned off of the ventilator, he goes home. 2 days later, he dies en route back to the hospital. You can say complication of COVID-19 infection, probable complication of COVID-19 infection. You can be more specific if he were to make it to the hospital, or if he were to get an autopsy in the hospital, or ended up coming to the medical examiner's office for whatever reason. You could be more specific. Pulmonary thromboembolism, as a result of COVID-19. But in this case, that would be an acceptable way to include COVID-19. And then the other thing is prior COVID-19 infections. Say you have someone who had COVID-19 5 months prior, and that was really their only issue. Or even if it wasn't, they just never got better. Like they stayed below baseline and then ultimately die from whatever reason. That would be an acceptable way to include COVID-19. Now, looking at that, the FEMA COVID-19 funeral assistance. Is everyone here that does death certificates aware of this funeral assistance? Anyone never heard of this before? I saw some hands. Okay, so FEMA, this came out, I believe, within 2020. So FEMA may provide funeral assistance under these following conditions. This is pulled from FEMA's website, and it is currently up to date per last night. So a U.S. citizen, non-citizen national, or qualified non-citizen. Basically, you can verify that they have been in the United States living. If the death occurs in the United States or territories thereof, COVID-19 was attributed to their death. Now, that's Part A or Part B. Doesn't have to be the direct cause. The applicant who fills out the FEMA paperwork is the one that's responsible for the funeral expenses. And they say January 20th, 2020. And then they cover up to $9,000. So this is important. I was wondering where that FEMA would go with this, because COVID-19 ended, the incident date for the pandemic has passed. That was May 11th of 2023. FEMA is still going to continue funeral assistance for COVID-related deaths until September 30th of 2025. So I say keep up to date on the website for that, because that could change. But this is from the CDC. And the question comes, well, this is a legal document. When should I be including COVID-19? Like, you need to be able to back that up. So here, the CDC guides, medical examiner, coroner, or other certified indicated that COVID-19 played a role. So COVID-19 must be specified on the death certificate. It has to be there. What they say in part, the second line here, is that you can say suspected, probable, may have, in order to indicate that there was a likelihood of COVID-19. It can be in Part A or Part B. It doesn't matter, as long as it's on the death certificate. Now, make sure, if you do include COVID-19, they may ask you to provide the evidence that they have had COVID-19. So for my purposes, that's not been an issue. For cases I've included COVID-19, it's either I have reviewed medical records and I consider that it either contributed or caused someone's death, or I've done an autopsy. Or I've had an examination where I've done a COVID swab and they've had shortness of breath and cough for 3 days before they die at home with no primary care physician. And in my situations, they just request my report and I send it, and I've never had any issues with that. But be aware that if they do apply for the assistance, especially if you amend a death certificate, they may ask you to provide that information. But it's a huge help for families. A lot of families in our area have included it. I've reviewed cases where someone else has signed a death certificate and family was suspecting, well, I think maybe COVID contributed. And I've looked back over and we've changed the death certificate. Or I've had physicians consult our office to say, do you think this is enough to include it on a death certificate? So I know there's going to be questions in a minute. I want to go to the references here, because I think death certificates, some people get great education on them, others don't. Others, the first time they see a death certificate is when someone sends them an email saying, hey, you have a death certificate you need to sign. So go to your Office of Vital Statistics. They'll be very helpful. The CDC is a great resource. Your local medical examiner, or your state medical examiner. Our state medical examiner here in Tennessee, if you were to call her office and ask questions, she's going to help you. So you can look at us like a consult. If you wanted to call your medical examiner and just say, hey, can I run this by you? We'd be happy for that. If you want to get my information afterwards and run non-identifiable information by me, I would be happy for that information as well. I mean, that helps families, it helps turnaround time, and there's great resources for you to look into. So speaking of vital statistics, many offices have PowerPoints and videos on their website to show you how to properly certify a death certificate. So if you have any questions about that, go through there, contact me, contact your local ME. We'd be happy to help you all. So with that, I think I'm done. Pass this over to you.
You want to come back up? We'll take questions for either of our previous lectures, Dr. Brewer or Dr. Harrell.
This is for Dr. Harrell. As a hospice medical director, we were told that anybody who did not come up to that had some accident, like an elderly person fell, broke their hip, and they never got back to their baseline that they were before they broke their hip, had to go through the medical examiner's office. And we always had to call. They usually said, it's okay, you go ahead and do the death certificate, but we had to call and tell them.
Yeah, so that's not how we do it where we are. So, and what I mean by that is if you have someone who has a fall and they don't get back to the baseline, our office at least, we consider that an accidental death. Like they fell, they didn't get back to baseline, same level fall. Now, we don't necessarily bring those decedents into our office to look at. We will review records and sign the death certificate. So I'm not sure where you practice.
In Knoxville.
Oh, So yeah, actually, I do know, well, one of my co-fellow is one of the MEs in Knoxville. So if you think that they didn't get back to baseline, and you do think that the fall contributed to your death, call and report it to that
Yeah, so
office.
we had to report it. They
Yeah.
usually let me sign the death certificate. They usually okayed it and said, you go ahead and sign it. But we always had to report it.
Gotcha. So interesting, because we will sign, our medical examiner's office signs all fall deaths. If the provider suspects it's related, or for us, actually, we review all cremation requests that come through for our jurisdiction. If we see someone tried to sign with a fall, or they, some sort of like protein calorie malnutrition, something vague, we get records, and if we see they fell, that becomes our jurisdiction, and we sign those death certificates,
I
so.
think a lot of our patients, there was still something else that was more complicated
Yeah, I'll put it in
than
Part B. I'll
the
put the
fall,
fall
but
in
they
Part
still
B.
they still wanted to hear about it.
Right. Well, and I don't know if they're doing chart reviews after the fact.
See, I
and-
don't know either.
Yeah,
don't
I would
know.
clarify with them and say, if you think that fall made them progress further, even though they're on hospice, that, to me, I put that in Part B of my death certificates, and that does make a difference to families, because some people have accidental death policies. So that's how I approach that. But you could always follow up, because I know Knoxville used to bring all falls in, but I would follow up with them to see if they have a new policy and procedure, because I know that they do review those.
Yeah, because I knew they reviewed them, but you should.
Other questions? Also from virtual as well.
So I had a patient that I signed the death certificate on who had multiple pulmonary emboli. And I learned after I signed the death certificate that he'd had a COVID vaccine 2 weeks prior. Do I need to go back and amend that death certificate?
That's a great question. From my understanding, the FEMA relief is for specifically COVID infections, not COVID-related vaccines. But there's a long kind of guideline that you can look at to see. But I believe it's only COVID infections or complications of the actual virus, not related to the vaccine.
But for statistic purposes, should I amend it so that it's statistically accounted for?
So, but you would have to be able to say that you think for certain that the vaccine caused the pulmonary embolism and it's not independent of the vaccine.
Yeah, he had no other reason to have a multiple pulmonary emboli.
So in those cases, we've had physicians call us and with suspicions that it was related to the vaccine. Early in the pandemic, we were doing autopsies on all those patients because we were trying to gather the information. Like, is there something here that maybe when they have patients have complications in the hospital and they're still alive that we're not able to see? So I've done those autopsies. What I would recommend in that case is contact your local ME and just run it by them and see if they want to review those records, and maybe that would be the best way to go before you amend a death certificate. But if you think it could be related, sure. I mean, you can do that. Amendments are just, you need an affidavit to do that. It's a good question.
Any other questions?
This is kind of twofold for both of you. So I'm from Cleveland, so I know you can't answer Ohio stuff specifically. But, so I had a partner who saw a patient once 2 years prior, physical exam, perfectly healthy. Went to the emergency room, chest pain, died of a heart attack, okay? My partner happened to be in the Caymans, and so now there's a forceful, hey, this death certificate needs to be signed. So of course it reaches my desk. I've never met the gentleman in my life before. The emergency room personnel refused to sign it. So first of all, are you allowed to refuse to sign it, number one? So then what I did is I work for a big hospital system in Cleveland. So I called our legal department just to get some advice. And the advice was, what do you care? You're not going to get sued for signing a death certificate. And I said, okay, I mean, I get it, but my name's on it. And I never met the patient. How should I have handled that situation?
So the question of should you be able to refuse a death certificate? Because there's a few questions there. People do refuse death certificates. The question is, are there implications? Sometimes the state ME will step in if it becomes a repetitive problem. I'll leave that there. And I don't know how Ohio functions. In terms of the ER physician refusing, that's, if they did, okay. At the end of the day, is it okay for you to sign it? Absolutely. If you review the chart And if you're not sure, if you think, okay, well, they have a history of hypertension, well, if you want to say suspected or probable hypertensive cardiovascular disease and natural, that's okay. As long as you review the records, that's going to cut out a lot of hardship potentially for the family. Now, being sued for the death certificate, if you went, well, mine's not up there, but when it says physician, it says to the best of my current knowledge, or to the best of my knowledge, there's some statement by there. I hereby certify the cause of death is the following. And to the best of your knowledge, if that is what you knew at that time, that is fine. The idea of being sued after the fact, I've not really seen it. Maybe someone has had personal experience with that, but the death certificate is designed in that way. And I do that even myself. I mean, I'm signing death certificates for people that I say may be homicidal deaths. But I do it to say to the best of my ability or best of my knowledge. So, yeah. So, physician, to the best of my knowledge, death occurred at the date and place and due to the causes and manner stated. And you can only go on the information you have, and if that's an H&P and the notes that your partner has, that's acceptable. That's fine.
Appreciate that. That's what I did. Thank you for that. And then Dr. Brewer, how about this primary care model? It's interesting because in Cleveland, so I had a resident who practiced for 5 years and just did this. Pretty fascinating story how he did it. What I want to know for you is, before you took that leap of faith, how long had you been practicing? Because you're not jumping out of residency to do this, obviously, right?
I've met occasional people that will do this right out of residency. I did not. I graduated residency in 2014, so I practiced in a couple different healthcare systems locally up until 2022. So for 8 years, I practiced with the man before going out and doing this myself. But I actually have spoken to people that have, a couple that have done this right out of residency, and that's a little crazy.
Yes, question regarding death certificates. I sign a few hundred of these a year. I manage a hospice practice as well. In regards to your patient who had the STEMI and VFib arrest, Part B, you listed COVID-19. From my understanding, the federal death benefits do not apply if COVID is listed under Part B. It has to be in Part A.
That's, to my understanding, not true, and it says that based on the statute. And if you go and read more, it does say that it did COVID-19 attribute to the death, and Part B are attributing factors. And so I've done it, and people have gotten the assistance. Now, if people have had difficulties and there's pushback, if someone called me and said, hey, they're not going to do it because X, Y, Z, I'd move it to Part A. I'd say, and probable. And if you feel, if that's how you interpret what's read, or if it's changed, that could be the fact too, is that the bylaws for this were updated when I made this presentation like 2 weeks before. So maybe at one point could it have been, and there's been a revision that I'm unaware of. That is certainly possible. I would check again, but because I've done it. But at the same time, if you're more comfortable and you want to make sure, I've put both options in Part A. But when I've done that, I've had a better history, right? It's not necessarily, I've had shortness of breath and they have a history of hypertension and then they have a COVID-19 that's positive. I do hypertensive cardiovascular disease and COVID-19, or you can say and probable, suspected. If you feel better about putting it in Part 1 and you want to say suspected, there's nothing wrong with saying that. I've put possible on a death certificate in Part A before, so it's totally fine. But that's my understanding.
Because I've encountered savvy funeral homes that are selling to the families like, look, make sure COVID's in Part A so you can get your federal death benefits. And if a family, because I've been requested to do addendums to the state, file an affidavit, moving it to Part A, because maybe they had a PE and that's why they had a STEMI and VFib arrest. But who knows? So ethically, could I move that? Would you, or if somebody queried you to move it, would you feel comfortable moving that up to Part A?
I would if I felt like I had the evidence that I could show to the federal government that I think it contributed. So yes, if you have someone who's it depends on the circumstance. If they had a rapid COVID-19 5 weeks before and were asymptomatic, I wouldn't probably be putting it on the death certificate in the first place unless I had some clinical history, some documentation in a hospital or by a physician or symptoms. But otherwise, I think that's case per case, and that's a great time, rather than talking to the funeral home about it, because I know that they have their interpretation can vary as well. Speaking to your local ME will help, but I would read through the statutes for the FEMA and see, because I've done it in Part B, and they say if it contributed or had any relationship to the death, so.
Okay, great, thank you.
Okay, we can take one more, I think.
Thank you. For Dr. Brewer, and I may have missed this in your very good presentation, on the deductible, in patients that have these really high deductibles, say $10,000 deductible, do they get any kind of credit in your system toward their deductible so that they're not still having to try to meet their deductible later when something big happens?
They possibly. They can take our office visit notes, and I can, give them make up a super bill and give to them to send to their insurance, and sometimes their insurance will credit that to their account as paying towards their deductible. But there's no guarantee that that's happening because insurance companies. But yeah, and what it does is it more puts that high deductible health plan more towards like a true insurance rather than a health plan. So if they have to go to the hospital for something major, then it's there. I also always recommend in those patients that have a high deductible health plan to do a health savings account if they can, because then that will help cover any of those high deductible costs if they're not getting any credit for our visits from the hospital.
Thank you.
Okay, we'll have to take a quick 4 or 5 minute break. If there's other questions, we can collect them later, or maybe they
Yeah,
can
or
hang out there in the
we
hallway.
can meet them out in the hall.
Yeah,
If
okay.
if anybody else has
Then we'll
questions.
start back in just 4 or 5 minutes. want this one of these? Sure. Okay. Just to see.
Is this advanced slides?
I think it's the green button.
Okay. Oh, I can show you that. Makes sense.
Okay, we'll go ahead and get started. Our next presenter is Dr. Karen Selk. She's currently a clinical assistant professor of medicine at the University of Pittsburgh Medical Center in the Division of Endocrinology and Metabolism. Dr. Selk graduated from LMU-DCOM in 2012. She completed her residency in internal medicine at UPMC, where she served as chief resident. She continued her training with a fellowship in endocrinology at UPMC, and upon graduation in 2017, joined the faculty. She currently serves as the clinical chief of endocrinology at UPMC Mercy. She is board certified in internal medicine and endocrinology and is also a diplomat of the American Board of Obesity Medicine and American Board of Lifestyle Medicine. Her current clinical interests include diabetes, obesity, lifestyle medicine, and lipid disorders. She is involved in resident and student education. Please welcome Dr. Selk.
I was just waiting for the presentation to come up. Oh, there we go. Oh, thank you so much for having me today. It's really great to be back in Tennessee. It's been 11 years since I've been here, so I'm thrilled to be here and to talk a little bit about something I get to see every day, and that is type 1 diabetes and technology. And so today I'm really just going to focus on type 1 diabetes, really not discussion on type 2. And so I don't have any disclosures to provide to you, but I do want to mention there are branded products as part of this discussion, because obviously generic things may not exist for some of these technology devices. And so our objectives today, we're going to provide a brief history on diabetes and past treatments for diabetes, describe the currently available diabetes technology for the management of type 1 diabetes, including continuous glucose monitors, insulin pumps. We're going to familiarize on how to determine an insulin pump candidate and contraindications for insulin pump use. We're going to describe pump terminology and how to troubleshoot insulin pumps. And then we're also going to review insulin recommendations for when insulin pump therapy should be held. And so I think it's important to first discuss some of the history of diabetes so we can appreciate really how far we've come with our medical advancements. And in fact, 2021 marked the 100th anniversary of the discovery of insulin. And so, yesterday, actually, like a lot long ago. So diabetes in antiquity. So there has been an awareness of diabetes since antiquity. There are descriptions in ancient Egypt of polyuria, polydipsia. Many describe that the Ebers papyrus presented here described a case treated with plant extracts. Some feel that maybe that's debunked, but again, recognition of this as a disease. In the 5th century BC, the Indian surgeon Shashruta described Madhumeha, honey-like urine, and the ability to attract ants. So how would they diagnose this condition? Lay urine out, do the ants come? This person has diabetes. What about the 2nd century AD? So you have the Greco-Roman physician Arrhenius, and he is the first one to introduce the term diabetes, and that is the Greek verb diabeno, I pass through. So, lots of urine is passing with diabetes that's untreated. And then you have the 17th century. So you have English physician Thomas Willis, famed for the Circle of Willis. He's the first medical writer to comment on the sweetness of urine. I'm not going to comment how he knows that in diabetic patients. And the term mellitus is given. And then in the 18th century, English physician Matthew Dobson demonstrates that there's sugar in the urine. And then the 19th century, diabetes is recognized as a disease of the pancreas by German researchers Oskar Minkowski and Joseph von Mering. And so basically, how do they know this? You remove the pancreas of an animal, they become diabetic. And then Claude Bernard first is credited with discovering glycogen and its role in glucose metabolism and really making diabetes something of interest in the research world. And so then you have the 20th century. Everyone knows Banting and Best, but it's Banting, Best, Collip, and McLeod in 1921 that extracted and purified insulin, and this was done at the University of Toronto. And in 1922, 14-year-old Leonard Thompson is treated with insulin in Toronto. So he is the first person with type 1 diabetes that is treated with this, newly created insulin therapy. And then in 1923, insulin becomes commercially available. This was made by Lilly Pharmaceuticals, and the Nobel Prize is then awarded to Banting and McLeod. And you can see Best is left out of there. And what's also kind of impressive at this time is, the patent for insulin was sold for $1. And so we think about that now and how much diabetes costs our patients in regards to their insulin therapy. It was really meant so that it would be affordable to all with this condition. And so, what did people do before insulin was available? And so in 1915 and 1922, American physicians Frederick Allen and Joslin promoted the starvation dieting. And so Joslin is, many of you are familiar with the Joslin Clinic, named for him. And so basically what they would do is starve people. People would be on diets that consisted of less than 800 calories per day. And the reason they knew this worked is in dogs, if you starve them to the point where they lose weight, and they're basically going in, you won't see glucose in the urine anymore, and then you can start feeding them gradually, and when you see the glucose come back, you kind of have to restrict the calories a bit more. So they did this to people, and you can imagine how cruel that would be. It really wasn't meant as a long-term cure, but more designed to extend the life of someone that had type 1 diabetes. And you can imagine how difficult this was. I mean, people died from starvation when they were treated this way. And in fact, one of Dr. Allen's study patients have said to have resorted to eating toothpaste and birdseed because he was so hungry. And then here on the right, we have pictured Elizabeth Hughes. So Elizabeth Hughes was the daughter of a New York governor, and she was diagnosed with type 1 diabetes. And at that time, she was really subject to this starvation dieting. I think she was on less than 800 calories per day, was basically starving, and then became one of the first users of insulin and lived to be in her 70s. And so what about, how do we monitor diabetes? I think we take for granted how we do this now, but really the ability to self-monitor glucose levels is one of the most important advancements in the care of people with diabetes. And so it wasn't until 1963 that dextro sticks were developed, and these would basically change in color in proportion to the amount of glucose present. And then in 1970, Anton Clemens developed the first glucose meter. And what's impressive about this thing is this device weighed 3 pounds. Can you imagine carrying something like that around with you? Probably more designed for an in-office use and someone wanted to find out their blood glucose. And then right now, which we'll talk about a lot today, is insulin pump technology. And so, we like to think that this is probably newer technology, but people were thinking about this as early as the 1960s. And here pictured is Arnold Kadish, and he had kind of designed this first closed-loop insulin pump. But you can see here, this kind of degraded photo, how huge this device is. It's like a military backpack. And again, not very practical for someone to kind of walk around with a device like this on a day-by-day basis. And so, just to kind of conclude some of the history, so, I like reading about history, where things, started, where they are now. And so this is a really great book by Michael Bliss, The Discovery of Insulin. And I would encourage all of you to read it if you have a chance. And so what about where are we today with diabetes management? And so, I like to kind of look at just a timeline, and again, brings up some of the past, and, kind of will show where we are now as well. So in 1908, we had Benedict's reagent. So basically this is glucose monitoring using urine. And then 1945, you have the CLIN test. So again, using urine. 1956, we're still using urine. And then 1963 is the dextro sticks that I mentioned earlier. This is the first time we're measuring glucose in blood. 1970, that's the dextrometer, so we can actually measure this with essentially a large meter. And then it really wasn't until the 1980s and 2000s that home capillary blood glucose monitors became accessible. And really the push was from Europe for this. 2004, we have the first FDA-approved continuous glucose monitor from Medtronic. And then in 2016, we have the first no calibration CGM from Libre. So it's by Abbott. And so before you had these continuous glucose monitors, but you still had to perform all the finger sticks. So it's kind of a drawback for a lot of people. And then 2017, you have your first FDA-approved closed-loop pump CGM system from Medtronic. And then 2018, you had your first implantable CGM from Eversense. And we'll come back to these. And so what's really important too is to think about the accuracy of a lot of the devices that people are using to make day-by-day treatment decisions for their diabetes. And so, you know, you can imagine someone has very brittle type 1 diabetes. We've all met these people, you know, they're making a decision how much insulin to take, and some people are taking half-unit increments. And so right now, what the FDA requires is that 95% of the readings are all within 15% of the glucose, and 99 within 20%. So you can have a 20% difference in the reading that you're getting. And I think we need to take that into consideration, why you sometimes see people don't maybe take the amount of insulin that you had prescribed. And so then what about accuracy? And so this is from 2018, where they're kind of looking at a lot of the meters that were available on the market. How accurate are these meters? And so what we would determine accuracy is within 50% of the reference range for plasma glucose over 100, or within 15 for that of less than 100. Again, we want people to make good decisions, if, you know, not have hypoglycemia. And you can see here, just to kind of, you know, draw the point home in the red, these are meters that are not meeting this, but yet these are being given to our patients. And so what is a continuous glucose monitor? I'm sure many of you are very familiar with these devices, but basically it's a device that allows the wearer to monitor their blood glucose every few minutes over a 24-hour period with minimal to no capillary glucose readings. And a lot of that will depend on what kind of CGM they're using. It's going to measure glucose in the interstitial fluid every 1 to 5 minutes. So again, important to kind of drive home this is in the interstitial fluid. And the reason that that's important is these devices will have a lag time. So what you're kind of seeing on a capillary reading may be different than the interstitial reading. There may be a difference, especially in periods of rapid changes with glucose. And so, you know, I think if someone says, oh, it says I'm low, but I don't feel low, you always want to drive home. You still want to do finger sticks in these scenarios. And then what about accuracy? So, you know, accuracy of these devices is really important. Again, people are making, you know, treatment decisions with these. They're being paired with insulin pump technology. We want it to be accurate. And so when we're looking at CGM accuracy, what we're looking at is the mean absolute relative difference, or MARD will be how it's referred to. And basically this is computed using data from CGM and then comparing that to glucose readings. And then that difference will be reported back as a percentage. If you see a MARD less than 10%, that is considered to be good performance from a CGM at this time. And every manufacturer should have this available for you, and then we'll kind of review what the MARDs are for the current CGMs available. And so, you know, CGMs, they have benefits, some drawbacks, but so, you know, what are the benefits of CGM? So obviously one of the big ones is to decrease the risk for hypoglycemia. A lot of people with type 1 diabetes, especially if they've had it for a really long time, they've tried to really keep their glucose tightly controlled, and a consequence of that may be impaired hypoglycemia awareness, so they may not actually have any symptoms at all. And so what do you do in that scenario? You let their blood sugar run higher because you don't obviously want harm to come to your patient. But if you have CGM, you can again try to get them back to target. The devices also allow you to avoid severe hyperglycemia. So these have alerts. People can see, oh, well, my blood sugar is running really high. I should take some insulin. And they may not have been aware of these trends when they were just doing, you know, standard finger sticks. We can reduce glycemic variability. So, you know, the thought there is you're going to reduce long-term complications for your patients with diabetes. And it also will aid with A1C reduction. And so A1C is always hammered into us, get it under 7%. And so CGM may help you get there as well. Patients have more data available to them. It's going to provide real-time feedback to the user, so they may find certain foods affect their blood sugar more than others, may allow the person to adjust their insulin more, maybe reach out to you more frequently for adjustment of their medications instead of, oh, hey, I'll see you in 3 months and we'll adjust it then. And then two, we're always thinking about the quality of life for our patients. And so, when using CGM, there's reported improvements in quality of life. They're not having these wide swings in their glucose maybe as frequently. They're not having to do these finger sticks all the time. And that's a big drawback. People, it hurts. And then also we compare this with insulin pumps to allow for delivery of insulin or suspension of insulin if someone is experiencing hypoglycemia. And so here listed are the current CGMs available as of this spring. And so let me find the little laser here. So we have your Dexcom G6 system here. And then one that's probably not listed here because it probably wasn't updated on their pictures, but the G7 was available, has been available as well. But again, another Dexcom product. And then you're going to have your Libre system. So this is the 14-day Libre system. I would say almost everyone has moved away from using a 14-day Libre system and instead are more on Libre 2 or Libre 3. I would say here this would be maybe more Medicare users right now, maybe more commercial folks are with the Libre 3. And then you have your Guardian Connect sensor. This is your Medtronic product. The 3 is the one that's been available, but that has still required some calibrations, which we'll talk about. And then you have your Eversense. Perfect. So to talk a little bit about Dexcom G6, so who will be a user of Dexcom G6? Someone who hasn't upgraded to the 7 yet. But most of this is going to be people that are on insulin pumps still because the G7 is not approved for use with closed-loop insulin or with insulin pumps. And so if you have someone that is on an insulin pump, don't upgrade them to G7 because they'll no longer get all the benefits from their pump. So a couple things on G6, as I mentioned, approved. You can use this with the insulin pump, so it's FDA approved for that. But a downside is it takes 2 hours to warm up. So someone puts that device on, and it really takes 2 hours to start seeing the data. It lasts for 10 days, so every 10 days, the user has to change the device, and it has a MARD of 9%, so again, less than 10%. So it would be considered good. And then you have your Dexcom G7, and so this is just for standalone use. So if you have somebody that's on insulin injections, has not wanted to go to a pump, this may be a really great option for them. And part of the reason that it's probably better is instead of having this 2-hour warm-up period now, that is now down to half an hour. And the other nice thing about it too is it doesn't just cut off on you. So if the users of the G6, it'll just stop working. It'll warn them it's coming, but it'll just stop working after that 10-day time period. With the G7, you now have a 12-hour grace period. So if someone was out and about, they're not worried that suddenly, oh, my device is just gonna stop working on me. And the other benefit is an improved MARD, so it's more accurate than its predecessor. And I would say the other benefit to this too is with the G6, you can kind of see, whoops, go back here. So with the G6 here, you can see there's like all these like pieces, this little long thing here. This is your transmitter, and you would have to save that for 3 months. So one of those would last you 3 months. Since you can imagine they can get lost, they can stop working. With the G7 model, this transmitter is built into it. So if you're familiar with Libre, it's similar to that. It's replaced every time you actually replace the device. And I would say most patients have been really happy with the G7. I think there's some, sometimes maybe it disconnects from the app a little bit, but otherwise people have been happy with it. And so what do you get when someone comes to your clinic? So if you have placed these devices on your patients, you can link them to your practice, which is really nice. If someone's having a problem with their blood glucose, they don't have to send you anything. You just log into Dexcom Clarity and you pull their data, and you can get a report back like this, or they're coming in for the appointment, you can get a report like this, and you can also bill for interpretation of this. And so what will you get back? So a couple things in your summary here, you'll get an idea of your average glucose. So again, this person's glucose pretty good, 133. GMI, so this is your glucose management indicator, predicted A1C. So again, 6.5 correlates with this 133. And then the thing that's becoming really important too is how much time does your patient spend in target range? And so really what we want to try to do is get most of your patients in this target range. Currently, we would accept something more than 70% of the time. And really, I think the most important thing here is really getting rid of the hypoglycemia. And, I think here this person's not having very much. And then two, what you'll get as well is you can get, this average composite picture. And so this can kind of give you your median range and give you an idea of maybe where you're seeing more deviations in glucose. And then you can also look in this in a day-by-day pattern, which would be kind of below. And then you can also kind of look at that in a more larger profile as well. And then you have your Abbott Freestyle Libre. So again, the 14 days just really fallen out of favor. And so most patients that you'll see now would be either probably on the Libre 2 or Libre 3. And so the Libre 2, this has a shorter warm-up time than the Dexcom, and the person places their sensor. It takes about an hour for the sensor to warm up and be usable. And there'll be a countdown. And this one has a little bit longer wear time, so a 14-day wear time. And the downside to here is someone's got a scan, so you've probably seen on television, they'll have this little reader, scan their arm, and then they can look and see what their blood glucose is. They can still get alerts though, so if they're low or their glucose is above target, depending where they have that threshold set, they can still get an alarm that does not require for them to scan to get that data. And this has now actually been approved for use with insulin pumps, so it's not yet being used, but I think what's nice is this is going to give our patients more options, because really people have been really limited to Medtronic and Dexcom to date. And the MARD on this is 9.2%, and I think that's important because when we look at Libre 3, you can see your MARD's a lot better, so more accurate if you can get your patient on the Libre 3. I think patients will like the Libre 3 sometimes a little bit better. It's a lot smaller. It's the size of a penny, and it's very thin. People probably have no idea that a lot of people are wearing these devices even. Again, still has that 1 hour warm-up period, 14-day wear time, but it doesn't require any of that scanning. And so someone can just have either a reader, which is coming, so they're making that, so our Medicare patients should be able to get this once that reader is available. But otherwise, you can just link it to an app on your phone. As long as the app is open, they can just look and see what their blood glucose is. And again, I think here the MARD is just a lot better, probably the most accurate available. And then, what kind of report do you get when you have someone on this device? You can link your patient here to LibreView. If they're using the app, it'll just pull it automatically to you. You don't have to have them upload anything. And so basically here, kind of like the Dexcom, you're going to get these kind of just statistics here. So you want to see, is your patient actually using the CGM? And you can also be able to tell that by looking at the daily log. But are they using it? You can see this person is using it 98% of the time. You can see, 14 days of data. Again, your GMI here, which is pretty good, 6.9. And then how much time is someone spending in target range, which is becoming really important. And then you're going to get your same ambulatory glucose profile here. So again, you can see this person has a really great morning, and then, breakfast happens. And then this is a picture here of the Medtronic Guardian sensor. And so the one that had been available to us had been the 3. And so I would say a lot of patients maybe didn't prefer this because it didn't take away the need for finger sticks. And so if someone was doing finger sticks and you're kind of going back to doing these pre-meal, 3 to 4 of them a day to get a MARD of 8.7%, or if you only did 2, your accuracy of the device actually decreases. But with the 4, you should no longer need these, so it may change. Warm-up times, kind of like the Dexcom, 2 hours. It's only a 7-day wear time, so you have to change this more frequently. And this will only pair with the Medtronic device. And then, just a couple notes on Eversense, just so you know it exists. Has anyone seen Eversense? Okay. I don't use this a lot either, and partly because it's really actually pretty invasive. And so basically this is a continuous glucose monitor that's placed subcutaneously every 6 months. So the person has to come in every 6 months and have this thing replaced and removed. And so basically it has this little tiny sensor, and this is actually what's implanted under the skin. So you have to use this big dilator, make a tract, and then this thing gets put in there. So again, if someone has like keloids, probably not a good option. But I think what's kind of nice about it is, a lot of people are private about their health. They don't want to have like some device that's out. And so if, they were going to a wedding or something, they don't actually need to wear the sensor part because you have to wear, the transmitter over top. And, if someone wants to take a break from it, it's easy. With a lot of these other devices, if you remove it, you can't put it back on, it's done. And so this would be an exception. And, for someone who maybe wants to use it off and on and doesn't mind having something implanted in them, this may be a good option. And then your MARD here is about 8.5. And so to kind of change tracks a little bit and move towards like insulin pumps. And so insulin pumps, as we all know, it's this external device pictured here. This would be a more standard one with the tubing that administers insulin subcutaneously as needed. So it's going to give you a basal amount of insulin just to kind of keep the glucose stable between your meals. And then it allows the person to bolus using the device for, meal boluses or even just correction boluses. They only use one kind of insulin, and that's really important. Sometimes patients don't realize that they're not going to be on, Lantus and Humalog or Novolog. And then this tubing or the infusion set is changed every 3 days on a tubed pump. If it is a pod, which we'll get to, that would be changed every 3 days as well. And that's important because insulin, when it's next to your body, it degrades, it becomes less effective. Some people will stretch it out, and you'll see before the time they're due to change this again, suddenly their glucose is running high. You can see they're taking their insulin, but the insulin is just not as effective. And so, what are advantages and disadvantages of insulin pump use? So, the advantage, this is going to more mimic what happens with the pancreas, right? Basal insulin, a bolus. It doesn't require injections. So a lot of people love being able to move away from injections. You can bolus a lot easier too. You use a bolus wizard, you don't have to calculate anything. You just tell it how many carbs you're eating and it will do the rest. It's really flexible. So, say someone is exercising. Well, you can't take away Lantus when it's been given, but with this, you can decrease your basal rate. So it gives people who are really active more flexibility. They're not having to eat all the time just to go be active. That, a lot of people feel defeats the purpose of going to the gym. And then you can administer different amounts of insulin throughout the day. So you'll find some of these people with type 1 diabetes have really high blood sugars in the morning before they wake up. They're not eating. It's, probably related to higher cortisol levels, growth hormone levels that happen in the early morning. And it's really difficult to, use a basal bolus, standard injection approach to fix that. Insulin pumps may work a lot better. Disadvantages, so you have something on you all the time, and a lot of people don't like that. You have adhesive. Some people can have adhesive allergies. It's expensive, potential for skin irritation. And just a quick, tip, one of the diabetes educators told me, if you have someone who seems to get a rash from the adhesive from these, have them spray a little bit of Flonase on the area, and it seems to actually help, believe it or not. These people they're at risk for their tubing kinking. The tubing can get blocked. They can get disconnected, and so they're at much higher rate for going into DKA than someone in injections actually. And then they have to be able to manage their pump, right? Or know what to do if it doesn't work anymore. So I think you always want to make sure someone has the basics of diabetes management. And so I think things when we're talking about pumps, what do we need to know? So we need to know our basal rate. So how much insulin do you need per hour to keep your glucose normal, between your meals? Insulin to carb ratio. So how many carbs does 1 unit of insulin cover to bring your glucose back down to normal? And you'll see this kind of expressed as 1 to 10. So 1 unit for every 10 grams of carbohydrates. Your insulin sensitivity factor, so how many points does 1 unit bring down your glucose? So not everyone should be on like a low dose correction scale. And then you have your target glucose. This would, I would say, most typically be set between 100 and 140, but you may have people that you want them to run a little bit higher, or maybe you need them to run lower. Pregnancy, right? So their targets are a lot lower. And then insulin on board time. So the amount of time a bolus is on board. And so, I would say pretty standard is to say a 4-hour, but if you have someone with end-stage renal disease, maybe you want to extend that out. They're not clearing the insulin the same way. Or you have someone who snacks a lot, you could actually lower it so they can actually get a little bit more insulin. And so, how should we get people on an insulin pump? And every place and every person will have their kind of own approach to this, but I think what's really important is your patient needs to know the basics, because this technology can fail, it will fail on them at some point, and they need to be able to manage this without, even if it's just temporary. And so you want to show that they're competent in carb counting. Can they calculate boluses? Because again, they're not going to have the device to do that for them anymore. Can they, do a correction dose? Can they calculate it? Do they know what to do when their blood sugar is high or low? Just kind of these basic survival skills. And then, do they know what to do if the pump's not working? Can they actually troubleshoot the pump to see if they can actually continue to use the pump? They need to understand the pump terminology. They need to be able to find their settings, because if they have a problem, you should be able to talk to them and walk them through, change this setting. They should receive diabetes education so that they can manage their insulin when they're sick or on steroids or not eating or exercising. And they should be able to transition back to injections at any point in the event of pump failure. So again, I think it's a good idea to have, these folks have a backup, basal bolus regimen available at their pharmacy, even if they're not filling it. And so how are we doing this in Pittsburgh? So, number one, your patient's got to want it. You can't want it for them. So if they got to express interest. And then we would refer them to our CDEs, where we basically would have them review carb counting, review the insulin pump terminology. They actually do a little quiz to make sure that they can perform well, so we know they know the basics. And I think it's important for them to kind of meet with the CD in person so they can touch and see all these devices, because what they think they may want may not be what they ultimately choose. And then basically you schedule and coordinate their pump start with a trainer so they know how to put the settings, they learn how to fill the insulin, how to place the infusion set or pod, and then how to use auto mode if they're going to use closed loop. And so how do we move someone to the insulin pump? So there's some calculations that you can do. You will find that patients use less insulin when they move to an insulin pump, and we need to take into consideration that. So it's usually taking 20% of the total daily dose. And again, we want to give half of that as their basal. So you're going to give it half of it. And then you give the other half as the prandial. And then if we want to calculate the insulin to carb ratio, this is just a fixed equation. So you do 500 divided by their total daily dose. And so that'll give you, something like a 1 to 10 that you can just place for the rest of the day. And then sensitivity factor, again, fixed equation. And that's the 1700 rule. So it's 1700 divided by the total daily dose. And that will give you your sensitivity. That's also helpful on the inpatient side. If you have someone who's really sensitive to insulin, you don't need to use the ones available to you. You can make your own patient-specific one. Then you want to set your target, so that'll be individualized for your patient, and then the insulin on board time. And so what pumps do we have available? So this is a picture here of the Tandem T Slim pump. Your reservoir with this pump is going to hold 300 units of insulin. It is a tube system, so the patient will have tubing with an infusion set. It will target a glucose of 110 if you have this set in auto mode, and will integrate with the Dexcom G6 currently. 2027, hopefully in the fall. And then it has Control IQ software, so this basically is going to use your CGM data through Bluetooth technology, and it'll allow it to predict the glucose over the next 30 minutes, and then adjust the insulin delivery every 5 minutes for the patient. And what's also nice too is if someone doesn't want to, they're at a restaurant, they don't want to take their pump out to bolus, they can actually do all the boluses through their phone. And this here is the Medtronic 780G. So this actually just got approved in the United States last month. They have been using it in Europe with great success. So again, this is going to hold 300 units as well. Is a tube system, and it will pair with their Guardian CGM, and it will actually allow a lot. Well, I think this is low 100 milligram per deciliter glucose goal, and it's going to again receive data from the CGM and allow adjustment of insulin delivery every 5 minutes based off that CGM data. And then you have Omnipod. And so Omnipod is the only tubeless system available. And again, 300 units. So if you have someone that is using a lot of insulin, you may want to consider U200. You just have to make sure you're really careful on your settings because everything needs to be halved. But this is the only tubeless system. It will pair with the Dexcom G6. Target is a little bit higher at 120. And the newest version here is Omnipod 5. I think the old Eros pods are slotted to be unavailable by the end of this year. And then, has anyone heard of a loop? Okay, so I saw one hand here. So you may encounter people who loop. And so loop is basically a DIY closed loop system. So think of it as someone hijacking an old insulin pump and putting in their own algorithm. And so what it has is an app, and it's an iOS app, continuous glucose monitor. It's typically it's a Dexcom, and then an old insulin pump, so some of these old Medtronic and Omnipods people may use, and then they basically connect all these devices with this thing pictured here, which is a Riley link. And so what's important is this is not FDA approved. However, in January, the FDA did approve Tide Pool Loop. So there is an app, people can do this on their own. So you may encounter this in your office if you do primary care. I think what your role is to really try to help adjust settings for people, make sure they're not hypoglycemic. But a lot of these people have really great control of their diabetes. And so since we have closed loop, what about, do we need to bolus? And the answer is yes. We're not there yet where the technology can just bolus for you. Hopefully we will be there, but we're not there yet. And so this is actually an example of one of my patients who, I will say her A1C did go from 14 to like 7.5, but she, as you can see here, she never boluses. These little droplets are correction boluses from that Control IQ software on a tandem pump. And so every one of these where you see a glucose excursion, her pump is giving her more insulin to try to correct it. And you can see it's never at goal. It's not necessarily terrible, but it's never at goal. And then you kind of see these lows happen. And so what's happening here is you're stacking a bunch of insulin, and then she drops. And so I think what's important is, if someone doesn't bolus still, they're going to have erratic control. They may actually go low. Their pump may suspend on them. I think the technology just hasn't caught up yet. So we'll see where we are in the future. And then what about imaging studies? So hopefully every facility where someone goes for any kind of imaging procedure should have a policy in place, and hopefully you're familiar with your site's policies. But I think these devices are very sensitive to radiologic studies, and you can actually destroy them by exposing it to them. And so I think you just want to make sure that your patient knows what to do with their device. This is our policy here in Pittsburgh. And so basically, we just make sure that, everyone in radiology knows what to do. They know to disconnect people from their devices. The thing that's a downfall would be, people really will be out of their sensor. They'll have to replace a new one. And this is just kind of a picture of how, people may disconnect from their devices. And so you have a tube system. Basically, all they have to do is remove, the tubing from the infusion set. And this can stay on as long as they're not using a steel infusion set. Some of them are true steel. Those that you'd have to remove if it's an MRI. But if it's this plastic one, it can stay, and then they just reconnect after the procedure. This is for type 2. Don't ever put a type 1 on a Vigo. And then this is the Omnipod. So basically, they're going to have to peel this whole device off. So they'll basically be out of a pod. And so what do you do if your patient is disconnected from their pump? So if it's less than an hour, don't do anything. They can check their glucose when it's done and bolus if they need to. If it's 1 to 4 hours, then they want to check their glucose before disconnecting. If it's more than 100, they can bolus a dose equivalent to 2 hours of their basal insulin. And then when they're, reconnecting, they can just see what their glucose is and then, dose. If it's more than 4 hours, they're going to be at risk for DKA. And so in this situation, you're actually going to want to give them Lantus. And so here you can give them about 70 to 80% of the total daily dose. If you don't know what they need, and there'll be people that have no idea where their settings are, you can give them 0.1 units per kg. They'll be high. They'll be probably really high in some scenarios, but they won't be in DKA, and you can correct them. If at any point they're going to be eating, during this period, just make sure you have some kind of prandial insulin ordered. Otherwise, it's just going to be greater than 500 on you. And then when they're ready to restart, what you can do, if they're using closed loop, is have them go into manual mode with a temp basal of about 10%. Until that Lantus has worn off, but they can still do all the boluses from their pump and then resume auto mode 24 hours after that Lantus dose has been given. And then here, what if someone's having surgery? So they can still wear their pump. So don't take them off their pump. Keep them on their pump. Just make sure anesthesia knows and make sure that, their infusion site is not going to be in the surgical field. And they should reach out to you too. What should their settings be beforehand? If they're on an auto mode, just tell them to put that thing in exercise mode. The target's higher, about 160. They shouldn't really go low. And if they don't have closed loop capability, then you can just have them run a temp basal, and you can give them somewhere 70 to 80%, depending on what their control is like. And make sure they always have extra supplies. People have things ripped off of them, and then they're stuck going on injections if they have nothing with them. And then who should we discontinue the pump in? Patient preference. If they were in DKA, they're suicidal, so insulin obviously could end someone's life. We don't want them having access to their own insulin. If they don't have their supplies, if they're sedated, so someone on a PCA pump, you may not want them to be on their insulin pump, or you find they're not appropriately using it. And so if you're going to disconnect them from the pump, you basically want to find their settings. And so this will be located in a different place for each of the pumps, but basically you want to find their total daily dose of insulin. And so we can see here, this person is using about 19 units of basal insulin. So you can give them 19 units of Lantus. Insulin to carb ratio, we see it's a 1 to 10. So putting them on a 60-gram carb-consistent diet, give them 6 units with meals. If you have Lispro on formulary, Aspart, doesn't matter. And then you're finding your insulin sensitivity factor, 40. So that would be your 1 for every 40. And then target, they have theirs set at 120. If they're in the hospital, you can use the 140. It's okay if they run a little bit higher. And then, insulin pump users and hyperglycemia, as I mentioned earlier, these folks are much more prone to DKA, and it can progress rapidly. So they should all be taught if their glucose is over 250, they should test for ketones. They need to make sure their device is working correctly. And then, if they test for ketones, if it's positive, then here they need to remove their infusion set, because the most common cause is going to be a problem with the infusion set. And then they can bolus based off their insulin sensitivity factor with a syringe, just so they know they have insulin and they're treating this, and they should go back out of DK pretty quickly. And then they want to check the glucose and urine ketones again in 2 hours. If it's not improved, then they got to go to the ER, unfortunately. If no ketones, then they first need to check the site, look for any kinking, make sure the pump's not suspended, and if no problems, they can continue to bolus through the device. If it's not coming down, it's probably an issue with the pump. Then they probably need to consider even going off and going to injections and reaching out to their provider. Exercise, so exercise lowers glucose before and during the activity and even hours afterwards. So you can have your patients use the activity mode if they're in auto mode. I tell people start an hour before your planned exercise, so you're a little bit higher beforehand. Continue maybe an hour or two afterward. If they're still having lows, you'll get people who run marathons and they're insulin pump users. I just tell them go out of auto mode and use a temp basal 50%, cut it way back, cut it back to what you need. And one of the, I think most important rules in diabetes management is don't feed insulin, right? You want someone to get insulin because they want to eat, not because they have to eat because we're giving them too much insulin. And then this is just a quick note on the Medtronic InPen. So I think this device is nice for people who maybe don't want to be on a pump, but they want some of the benefits. And so these people have access to that like a bolus wizard. And so basically this pen is a smart pen that will connect to, it can connect to CGM actually and pull the glucose over. But actually helps with dosing. And you might want to consider this in someone who doesn't like math. So they don't like math. They don't have to do any math. They can just, see where their glucose is. If they have complicated carb ratios or they're really forgetful, did I take insulin or not? This will track it. And so this will be kind of what their app looks like. You'll see, calculated doses, duration of therapy, glucose, all those settings, just like on the pump. And then when you go to the office, they can generate a fax and you can see all the CGM data. So that's your purple line here. And then all these little things are boluses. And you can see here, boluses are close to one another. But if someone takes boluses that are close to one another, the app will actually subtract out some of the insulin too. So they're not as prone to hypoglycemia. And I think one thing I wanted to drive home is, all this technology that's available, diabetes is still really difficult. And I think sometimes if you don't live it, you don't realize that. I became so obsessed with my blood sugar levels on the app, I just stopped eating anything. And there were days I just didn't know what I was learning, and I was worried diabetes would ruin my entire future. I remember spending nights crying, feeling misunderstood, and feeling so alone. And so I think kind of just seeing where people are coming from and, acknowledging things may not be perfect on a day-by-day basis. And so just a couple notes on like where diabetes is going, and I'll try to be quick with this. So Apple's working on a watch to check glucose that wouldn't require any access to interstitial fluid or blood, just like how it tracks our pulse ox and heart rate. And then 2, pictured here, this is a contact lens that can measure blood glucose. So the glucose in tears is actually very similar to what's in our serum. And so if you have a way this lens can measure it, and this has been developed in some early models already, and then it has a little chip in it that can actually send back the data to a receiver. So more stuff from maybe less invasive ways to monitor maybe coming. And then you have stem cell derived islet cells. So can we actually give people, cells that make insulin back? And I don't know if any of you read this article in the New York Times, but they've done this. And so they have basically taken a stem cell line and differentiated this into islet cells, which make insulin, and they infuse that into the portal vein, which they've been doing that with cadaver ones through the Edmonton protocol for decades now. Just required a lot of people to die, unfortunately. And then here they can infuse it, but the problem here is this requires immunosuppression. And they've actually have cured people of their diabetes. They're not on insulin anymore. And this is a gentleman where that was the case. He lives in Ohio somewhere. And I meant to go back, but the next step in this is actually to develop a capsule around the cells so that it's not exposed to the immune system of the recipient, so that no anti-rejection medications will be needed. And that's expected to roll out sometime in 2024. And I guess one downside for this is someone has to have type A blood to receive these, because I think that's what the donor had. And then here we have Tzield or tepezolizumab. And so this is the first disease-modifying therapy for type 1 diabetes. And so, when do endocrinologists meet people with diabetes? Well, they have high blood sugar and they need insulin, right? I think where maybe, and maybe, is we detect people who are at risk for this and treat them before they have the disease? And I think this is also, a big role for primary care even, because who sees all their relatives? The primary care doctor, we don't see them. And so basically what happens in diabetes is you actually have multiple stages. So first, the immune system's starting to attack, the beta cells, but their glucose is fine. Stage 2, you'll start to see dysglycemia, but the person doesn't need insulin. And then 3, they're just not making enough. And that's when diabetes is diagnosed. So now what we can do is give this anti-CD3 antibody to hopefully actually prevent hyperglycemia from occurring. And this was approved by the FDA back in November 2022. And so in a study of 76 participants that were high risk, so again, they have antibodies and some component of dysglycemia, the mean time to diagnosis was 48.4 months if they got the treatment, and 24.4 with placebo, so maybe it does delay things. And 43% of those who received the treatment developed diabetes versus 72% in the placebo group. And this can be given, it's available now. I don't know if anyone here has given it, I have not given it, but I do know our insurance will cover it. But if you can give these to people age 8 and up who are high risk, and they defined high risk as someone that has 2 or more antibodies, and these are all you can send out commercially, and an abnormal OGTT. So this would not be your A1C, it would be the formal OGTT. But I think here what's really important is it's really expensive to treat one person. It's probably around $200,000. And then there's no guarantee they're not going to have diabetes. But I don't know, if it extends it out, maybe there is some value to it. So I'll wrap it up. Thank you. And I don't know if anyone has questions.
I'm a pediatrician, and just a couple of days ago, mom of my patient who's a type 1 said that her endocrinologist recommended her 2 children have some blood testing that she was going to get at home and send off. Is that referring to specifically what you were just talking about?
Yeah, so through a lot of, I'm not sure if anyone's familiar with TrialNet, but it's this big consortium in the United States, and it's usually children's hospitals. And basically what they've been trying to do is identify family members of someone with type 1 diabetes to determine if they're at risk. So yes, that send out should be to look at the antibodies.
Cool. Other questions? Okay, we'll take like a 5-minute break. we'll get started. Our next presenter is Dr. Che Soya. He is a Knoxville native with clinical practice that includes perioperative anesthesiology, as well as acute and chronic pain management. He completed undergrad and medical school at the University of Tennessee. He completed residency at Walter Reed National Military Medical Center in Washington, D.C., and pain fellowship at the Weill Cornell Medical Center in New York, New York. He currently serves as assistant professor of anesthesiology and medical director of the multimodal acute pain service at UT Medical Center in Knoxville. And our next two speakers will count for the Tennessee proper prescribing course. Please welcome.
All right. Is this on? All right, thank you. Good morning, everybody. I'm Che Soya. Today I'm going to be talking to you about the multimodal, multidisciplinary approach to pain management, specifically intended for primary care providers. The objectives of this is not only to help primary care providers provide the best pain management in their clinic, but also to identify when to refer and to where what clinics are going to get your patients the most optimal care. Is there a way to advance slides? Or? Green. All right. I have no disclosures. Specifics of what we're going to talk about. We're going to first talk about how we've gotten to where we are in this ongoing opiate epidemic that's been going on now for well over a decade. We'll discuss the CDC guidelines. Dr. Denham, who's going to be speaking after me, will get into the real nitty-gritty of that, so I'll kind of briefly go over that and defer most of that to her. We'll discuss why pain control is important, both identifying and treating acute pain and before it becomes chronic pain, and then how to deal with patients that have had long-lasting chronic pain. We'll discuss the underlying theories behind chronic pain, namely the wind-up and central sensitization phenomena. We'll discuss what is involved in multidisciplinary and multimodal care pain management, the interventional options that we have, and how to identify which patients would benefit from which particular procedures, and the role of opiates, obviously, in pain management, and how we can use different screening tools to optimize their use. So as you can see, this is from 2014, but it's still pretty relevant today. The epicenter of the opiate epidemic is the Appalachian region. Southwest Virginia was one of the main targets of the Purdue Pharmaceutical group when they were having their big times in the early 2000s. And it is still an area with a significant problem with opiate overdose. It's gained a lot of attention. In the early 2000s and 2010s, the main driver of opiate overdose was prescription opiates. However, that has now changed into illicit drug use, and there is some or illicit forms of opiates, and there is some thought that that may be because of the strict rules that have been put in place, that patients that were previously turning to these prescription opiates are now going out into the black market to find these medications. But we do know around 59% of patients of drug abusers that have been studied, opiate drug abusers, do report that their initial exposure to opiates is a legitimately prescribed opiate. This is another very interesting graph that was pulled from a publication in the Washington Post that kind of highlights the cultural differences we have in this country as compared to other Western developed countries. So you can see per capita, the French actually have more chronic pain than we do in the United States. However, we far outpace the French in terms of how much opiate we prescribe. And I always refer to the fast food culture, the instant gratification. There is something in our culture that we want immediate results right away. We want better living through chemistry. So there's a lot to unpack with this graph, but very interesting. So how did we get here? The initial laws that were put in place to prevent opiate misuse were back in 1914. the Harrison Narcotic Control Act. Prior to this, heroin, morphine was commercial or freely available without a prescription. And up until the 70s and 80s, there was not a large problem with opiate prescribing for pain, for chronic pain. However, in that time period, a lot of journals started to come out and say that we were undertreating pain, that if opiates were used for chronic pain in the right way, they were rarely resulted in addiction. And then in 1986, the World Health Organization came out with the cancer pain monograph, which we'll kind of go into, that was specifically intended for cancer pain, but became a monograph for all pain for a lot of providers. And then probably one of the biggest things, the thing that I remember from my early training was this concept of pain as the fifth vital sign. And basically using a subjective number that was reported by a patient that can vary from person to person depending on a lot of different things, and treating that number and using that as a fifth vital sign. And that was Joint Commission also really was big on that in the early 2000s to require assessments of patients that included pain assessments. So this World Health Organization ladder that came out in 1986 intended for cancer pain, generalized to all pain, and as you can see, it's grossly oversimplified. The second rung of the ladder is already talking about using opiates. They talk about adjuvant therapy, doesn't really get into what that is. It's a unidirectional ladder as opposed to a bidirectional ladder. So quickly leading to use of opiates if you're following this monograph. And the World Health Organization has subsequently come out with a new monograph, which we'll discuss, that is not perfect either. But what really started everything was the extended release formulations of opiate medication that started in the late 90s, namely OxyContin. They had a very strong marketing campaign around it, and it led to, in 5 years from 1997 to 2002, a 925% increase nationally in opiate prescriptions. There was thinking and some research which was subsequently found to be influenced by money, that there was less likelihood of abuse in extended release formulations of opiates compared to immediate release forms of opiates. And in this time, you saw quadrupling, as we were talking about, of opiate sales. You saw increased disability, a plague of hyperalgesia, which we'll get into. Different sort of endocrine and psychological comorbidities emerged, hypogonadism. And despite this rapid increase in opiate prescribing, there really is no evidence to support, or level 1 evidence to support, its long-term use for chronic pain management. So I'll kind of skip over these slides because Dr. Denham will be talking about what the CDC specifically has said about this. CDC has gone back and forth. A few years ago, they put out guidance that was a lot more strict. Just recently, they've come back and the pendulum has somewhat swung in the other direction, but we'll get into that in our next hour. This is an example of a risk stratification tool that I hope a lot of you are using that helps identify patients that may be potentially at risk for opiate abuse or misuse. As you might imagine, a personal history of illegal drug use or alcohol use is a risk factor. A certain age demographic is going to be a risk factor between 16 and 45. History of any sort of sexual abuse, psychological disease, in particular bipolar disorder, are risk factors that you need to factor in when you're thinking about starting someone on these medications. And particularly, I would say age, because if you're starting somebody on an opiate in their 20s or in their early 30s, they're going to develop a tolerance to that, and it's going to be a difficult path for them because they got a lot of life left to live. So getting back to the new World Health Organization ladder, they've added a fourth step. They've made it bidirectional. And that fourth step is kind of where we as interventional pain management physicians come into play. That's the invasive and minimally invasive treatments. I would argue that that should be maybe step 2, and we'll get into that. Before you start patients on opiates, you might want to consider referring a patient with a obvious, pain complaint to a interventional pain physician, and that may be able to stop them from progressing to those other things. And at the very least, they can give you back some input about what they think the best options may be, and that may include opiates, depending on the patient. So there's a lot of reasons why pain control is important in the short term. When I do a lot of inpatient pain management, there's a lot of potential complications associated with pain, acute on chronic or acute post-surgical pain, tachycardia, pulmonary complications, increased stress response that leads to thromboembolic events, poor sleep hygiene, needless suffering. And that acute pain will ultimately develop into chronic pain through these theories of wind-up and central sensitization. It can lead to other psychological comorbidities, in particular depression, dependence, and something we call catastrophizing, which is kind of an anxiety-provoked, an anxious state associated with pain where everything is bad, everything is the worst, nothing's going to help. So wind-up is a phenomenon that happens peripherally. It is primarily in the C fibers, which are the main pain fibers, and they result from a painful stimulus that as it lingers increases action potential both in terms of magnitude and duration, and that will lead to effects on the spinal cord centrally that can cause hyperalgesia. So in the central spinal cord, you'll get repeated C fiber stimulation in the dorsal horn that leads to a displacement in magnesium on the NMDA receptors, increases output in the dorsal horn, and enhances the response to subsequent stimulation. So what can we do outside of opiate prescribing? There's a lot of different options, and I would encourage patients to try these sorts of things before you get too carried away with opiate prescribing. Obviously, physical therapy has some of the best data for long-term management of chronic pain. I can't tell you, when I was a fellow, I rotated in a PM&R clinic and was just amazed by the results of those of that clinic, just physical therapy. Having people be active. Functionality is the biggest thing here. It used to be a number. We used to look at pain as a 5th vital sign, but really we're looking at how functional are you. If I can get your pain to a 0, but you're laying in bed all day, that's not what I'm looking for. If I can get your pain to 4 or 5, you think that's okay, you can do the things you need to do every day, that's the sweet spot. And physical therapy is very helpful in that. Obviously, what we do, I think, is helpful, the interventional things, using non-opiate medications first, and we'll get into the indications for certain non-opiate pain medications. There are behavioral health options. These are kind of hard to find in this community here, the cognitive behavioral therapy and biofeedback, basically getting patients to understand what are the triggers for their pain and teaching them ways to avoid those. Biofeedback is where they actually take parameters like heart rate, respiratory rate, and try to tie that to certain activities and see how they can keep those levels at a baseline. Obviously, there are surgical options for some patients. What we commonly see in our pain clinic is patients that are first sent by primary care to a neurosurgeon and then brought to us because they didn't feel like either they were a good surgical candidate because of comorbidities, weight, or they thought they should try something more conservative prior to surgery. And then complementary medicines. Acupuncture actually has evidence behind its use. This is not anecdotal. They've done PET scans and looked at the analgesic centers in our brain, and there's something that we don't really completely understand about acupuncture that does provide pain relief. As far as I know, Medicare still will cover some sessions of acupuncture for chronic back pain, so it is something to consider for your patients. Obviously, massage, Tai Chi, mindfulness, yoga. What I always say is, you know, when we see people, especially in the inpatient setting, you always walk into a room and the room's always dark, patient's always sitting in bed, and they talk about their pain. And, you know, it's important to keep yourself occupied. Patients usually report most pain at night, and there's no surprise to that because they have nothing else to think about except that pain. So being active, keeping your mind active is going to be something that people don't necessarily appreciate as a pain treatment, but it can be. So why is multimodal pain management so important? Well, there's synergistic effects. We're working at multiple different receptors many times with the medications we offer. And the big goal, the buzzword that we like to use is opiate sparing. Opiates have a place, obviously, in pain management, but if you're using them as a unimodal therapy, you can get into trouble. Opiate-induced hyperalgesia, increased tolerance, and increased levels of these medications will be required, especially if you're starting at a young age. And the concept of preventative analgesia is something that goes back to what we talked about with wind-up and central sensitization. Is if we can stop this pain early, if we can identify a potential chronic pain issue early, then we can do a better job at treating it. So, you know, the example would be if somebody was working out in their garage and they now have a sciatica complaint, waiting 6 months or a year before that gets addressed is going to most likely lead to a worse long-term pain outcome for them, as opposed to getting them in, getting an epidural steroid injection, getting them into some physical therapy. So we'll go into a few of the non-opiate pain options we have. Obviously, Tylenol, acetaminophen is a great option. It's a COX-3 inhibitor. It doesn't have the platelet dysfunction components or GI adverse effects or renal adverse effects that NSAIDs have, as well as the not having the concerns for bone healing. When you tell a patient, you know, I want you to make sure you take Tylenol scheduled, they'll often roll their eyes at you, but there's plenty of evidence to support that this does have a significant effect on opiate use. The number needed to treat for patients that receive a combination of NSAIDs and acetaminophen actually is lower than patients that just receive oxycodone. NSAIDs, another excellent option. If patients, you have to be more careful about these, obviously. As we mentioned in the previous slide, gastritis, renal impairment, platelet dysfunction. If you have somebody with a recent fracture, you want to be careful with these because they can delay bone healing. But in the right patients, another great opiate-sparing technique. Neuropathic agents have been used with great success. We do it a lot off-label, so primary indications are postherpetic neuralgia, peripheral diabetic neuropathy. We use it for radiculopathy, which we see as a kind of a neuropathic pain state, and have pretty good results with it. There are several different types of neuropathic agents. They work at different receptors. Oftentimes we'll use more than one at a time. If we've kind of maxed out use of one, we can try another. What I will say, though, about neuropathic agents is for a long time, they were used as kind of an alternative to opiates, but you really have to be mindful of why you're prescribing it. If somebody has somatic pain as opposed to neuropathic pain, I would not recommend using it. There's now a black box warning for gabapentin in terms of co-administration with opiates, so this should be used for a true neuropathic pain state, a dermatomal or nerve distribution pain state that is described as burning or associated with numbness. Tramadol is one of those weak opiates that they refer to in the pain ladder that we looked at previously. It has affects at multiple different receptors, so it is useful from that standpoint in terms of its potential to help with neuropathic pain. It is a weak mu-opioid receptor agonist, so a lot of times people will be put on this because it's considered a weak opiate. But again, you know, this is something you want to keep in your back pocket as well. Anticonvulsants like gabapentin and pregabalin, obviously, in the right select patient populations can be very useful. They reduce calcium influx at the calcium channels and activate spinal noradrenergic activity, which reduces spinal cord excitatory amino acids like glutamate, which is one of the main pain neurotransmitters. It can cause dizziness, drowsiness, fluid retention, weight gain are some of the big issues that patients with on gabapentin report. And it can be used to decrease the amount of opiates, again, in the right patient population. So we'll get into a little bit about what some of the things we do, how to identify patients that might benefit from intervention. Probably the main thing, the most common procedure that we do in our pain clinic is an epidural steroid injection. There are different approaches to this. This is for what is commonly referred to as sciatica, or is what we like to call radiculopathy. So herniated discs, bone overgrowth, ligamentum hypertrophy that causes impingement of the nerve root as it's exiting the spinal cord. Also lumbar stenosis, which presents differently, not the classic radicular complaint, usually a kind of burning pain in both legs, can often have a weird presentation, but you know, once you get that MRI, it's usually pretty obvious what's causing that pain. So there's a lot of different thoughts in terms of the mechanism of action. We use a particulate steroid. Some people use local anesthetic as well. There's a belief that it decreases obviously the anti-inflammatory effects of the steroid, decrease cytokine production, decrease ectopic discharges from injured nerves, depresses conduction in unmyelinated C fibers, those pain fibers. It can increase blood flow to ischemic nervous tissue when you use local anesthetic. And just the act of washing out those inflammatory cytokines may be beneficial. Can decrease scar formation and cause some adhesiolysis, and can decrease capillary permeability and reduction of edema. So it's working in a lot of different ways. I always tell patients that I do an epidural steroid injection on, also the genetic effects, that it takes around 72 hours to notice an effect, because I personally don't like to use local anesthetic. I just use steroid medication. I think that a lot of times when you use local anesthetic, it's so powerful that patients will get that anesthetic, the local anesthetic relief for 8 hours, and they'll say it only worked 8 hours. So if you take that out of the equation, you're able to better verify whether it worked or not. You say it's going to take 72 hours. It's not going to be something that just all of a sudden you have no pain. If that does happen, great, but most likely it's going to be a slow reduction in your pain. And maybe your pain doesn't go away completely, but your pain may improve. And it's important when you assess these patients afterwards to really get an understanding not only of what they're reporting to you as their pain relief, but hey, you know, my pains are the same, but you know, I can do an hour more of chores than I used to be able to. Well, you know, maybe you are doing better. So the other thing is that patients are not very don't tend to remember how well these things work long term. I can't tell you how many times I'll have a patient come in a month after an epidural. I say it's working great. Then you see him 6 months later, they said the epidural never worked. And you know, I'll tell him, I have this note that says you told me it was working a month out. So it's really important to quantify and qualify how it worked. These are the two different approaches that we use, or there's actually a third approach, but this is two of the three. So there is the interlaminar approach and the transforaminal approach. There are risks and benefits to both, which we'll get into. The intralaminar approach is what is commonly used in for labor epidurals. We're basically going through the interspinous ligament into the ligamentum flavum and putting the medication in the posterior aspect of the conus. This is the spinal cord ends at around L1, so this is just the conus at this point. And we're hoping to get that medicine to move anterior, because usually, and this is not always the case, but usually the pathology is going on in that anterior component. Is there a laser on here? So, with herniated discs, you have the disc pushing on that anterior surface of the nerve root. Now, with spinal stenosis, that may be different. There may be ligamentum flavum hypertrophy that's causing it, bony overgrowth, facet, these are the facet joints, facet hypertrophy that's causing the spinal stenosis. So really having a consideration of where the impingement is coming from is important in determining it. There's also risks associated with the transforaminal that are not as prevalent with the interlaminar, so oftentimes we will start with the interlaminar approach. There's also the caudal approach, entering through the sacral hiatus for patients especially that have had back surgeries. So just because a patient has had laminectomies and hardware there where they really don't have an epidural space that we can tap into at that level where the pathology is going on, putting the medicine in the sacral hiatus, using some volume to get it up to that level is actually very beneficial. And we'll get into some of the studies there. So intralaminar versus transforaminal. Transforaminal is superior within our literature. There's a lot of downsides to it, which is why we don't necessarily use it right off the bat. So it has the best proportion of studies demonstrating benefit. Caudal even has better results than interlaminar. But again, we usually stick to the interlaminar to start. We use fluoroscopy for all of these. This is important because about 53%, there's a 53% rate of false loss. So we use contrast to determine that we are indeed in the epidural space and make sure that we are depositing that medication where it's going to have the best effect. This is kind of an example of what it looks like under fluoroscopic guidance, the intralaminar space. This is the intralaminar space where we're placing the medicine. This is the transforaminal approach. So you can see the pattern of the nerve root here. This is a nice pattern where we're seeing the nerve root where the contrast is primarily going medially into the spinal cord, following it, tracking it back up. So that's a nice picture. Cervical epidurals. We also do cervical epidurals for cervical radiculopathy, so pain that's radiating in a dermatomal distribution in the arms and hands. This is performed in a similar manner, but obviously at the cervical level, it's a much more high real estate area. The epidural space is smaller. It sometimes terminates at a different level. I don't go above C7 because in a lot of patients there is no epidural space that high up. So you have to be much more careful with these patients, but you do get good results from cervical epidurals as well. Intralaminar really is the only option here unless you're dealing with an interventional radiologist who's using CT guidance because you have the vertebral artery at this level. You have cervical radicular arteries. So transforaminal, I've done them before. They're not fun to do. The composition of the steroid is important. We primarily use particulate steroids, which is kind of a white milky substance which has small particles of steroid in a solid form. This is thought to be superior because those particles disintegrate over time, and it's thought that they give you a longer pain relief when compared to non-particulate steroids like dexamethasone. In the studies, there is equivalence between the two, but anecdotally, the particulate steroid does work better. And particularly in the transforaminal approach, you have to be very careful about particulate steroid because there are radicular arteries at those levels. So if a particulate steroid did get intravascular at those levels, there is the potential for a spinal infarct or for a stroke. So there is some good indirect data that is positive with epidural steroid injections. They decrease the need for neurosurgical intervention. They have a better return to work, and they decrease healthcare utilization. What they don't seem to decrease is opiates. We can get into why that is. There is some secondary gain, obviously, associated with opiates. So that's why it's important to identify these patients early, before they're on large quantities of opiates, so we don't get to this point. The complications, very rare, but infection, the biggest, scariest one is an epidural abscess, which usually occurs several days afterwards, associated with fevers, associated with pain out of proportion to exam, and motor weakness. Anytime you have a patient that has had a recent epidural that is reporting any sort of new onset motor weakness after the procedure, you want to make sure that they get an MRI quickly. The thromboembolic events we've talked about that can lead to neurologic sequelae, and then local anesthetic and corticosteroid-related complications. Obviously, steroid has side effects that we'll get into, as well as local anesthetic. If we unintentionally go through the epidural space and get into the intrathecal space and put a local anesthetic there, they're going to be numb for several hours afterwards, which is another reason I don't like to use local anesthetic. If some of you may remember, about 10 years ago, there was an outbreak of fungal meningitis that occurred after patients received epidural steroid injections. This was a result of unsterile technique in the compounding of the medication. Interestingly, despite Medicare paying for it and private insurances paying for it, the FDA does not, spinal administration of steroid is not FDA approved. The other big issue with this, epidural hematoma, that's a little more faster onset than the epidural abscess, especially in patients that are on anticoagulation or antiplatelet therapy. Depending on the type of therapy that they're on, there are different indications on when they need to stop it, and we always get approval from the prescribing provider in terms of whether to stop it. I can tell you, I do anesthesia as well as pain, and I have seen patients come in with strokes because they were held, they had a antiplatelet therapy held for a procedure. So it is not a free lunch to just tell somebody to come off of it. It's a risk-benefit analysis. For epidurals, they absolutely need to come off these medications. There are other procedures that we do that are not near the spinal cord directly where we will let them stay on, and they may develop a hematoma afterwards, but less likely to have anything catastrophic like with an epidural. The thromboembolic events, basically just case studies on this, but enough to warn us to use particulate steroid when we do the transforaminal approach, which is closer to that radicular artery. Don't really see that in the intralaminar approach. So that's why we tend to use particulate in intralaminar and non-particulate in transforaminal. The neurologic complications, arachnoiditis can occur. That's actually more common with the intralaminar, as you might expect, than the transforaminal, because we're actually up against the arachnoid mater there. Often mimics radiculopathy, so something to be mindful of as a potential issue after an epidural. Damage to nervous tissue. With the transforaminal, as you might expect, you're coming right up against the nerve root, so more likely to have an issue with nerve injury with that. Intradiscal injection, if we are advancing the needle too anterior, we can have an issue there. And inadvertent dural puncture. So dural puncture headache, post-dural puncture headache, commonly associated with headaches worse with standing and improve or disappear with laying flat. Usually for these patients, if we do get them, we'll tell them, drink fluids. Caffeine is very helpful for them. As a last resort, we will do what's called a blood patch, where we repeat an epidural with blood to create a patch over the dura. That's another thing to be mindful of in patients coming back to you after an epidural. Allergic reactions with any sort of procedure or possibility, LAST or local anesthetic systemic toxicity, another potential complication associated with the procedures we do. Especially if you're, again, that cervical transforaminal being near the vertebral arteries, very high risk for that, as well as thromboembolic events. So the big things with steroid-based injections, most of the things that we do are steroid-based. They can affect your bone deposition and resorption. So patients with osteoporosis or pathologic fractures, we try to limit or avoid, depending on the situation. We'll sometimes have patients we schedule for a procedure. Between their procedure scheduling and when they show up, they break a bone. They show up for a procedure. They have a broke bone. I say, we can't do this procedure right now. You need to get your bone to heal before we do that. It can cause HPA suppression, which is why we only usually offer around 3 to 4 steroid injections a year. Because of that risk, in patients that are diabetic, we usually want them to have some degree of diabetic control before they show up for an epidural or another steroid-based injection, because it can cause a significant elevation in glucose for 2 to 6 days. And then obviously if anybody's on any sort of antibiotics, has a concern for an infection, steroids are immunosuppressant, so we hold off on doing injections on patients with any sort of infections. So who needs an epidural steroid injection? We kind of talked about it. So pain in a dermatomal distribution, classic dermatomal distribution. If you have that, one of the tests you can do in your clinic is called the straight leg raise. Have the patient lie supine on the examination table. Keep the knee neutral and bring up the leg. That creates a shooting pain and a dermatomal distribution down your leg. Very commonly can be associated with radiculopathy or what is referred in layman's terms as sciatica. The next step there would be getting an MRI to confirm this. Or you can send them to a pain provider who can do this, but that can help facilitate getting them the care they need quicker. The other big injections that we do, so facet joint injections, the facet joints refer to the joints in the spine that articulate between the vertebrae. There's 2 on every level. They are innervated above and below by the medial branches, which come off of the nerve roots at the above and below levels. And very classically, this sort of pain isn't the type that radiates all the way down the leg. So you'll have patients that'll say, we refer to it as axial back pain, so pain that's kind of focused above the belt line, worse with rotation of the spine, worse with torquing them back. So this is called facet loading, when you have somebody do some lateral range of motion and then bring them back. If that causes pain on that side, that's most likely facet mediated. They can have referred pain that goes down their leg, but usually it stops above the knee. So for this, we do medial branch blocks, which is a diagnostic procedure. So we're hoping to get around 50 to 80% relief for several hours afterwards. Patients usually go home with a pain diary. If it improves their pain significantly, we can ultimately do a radiofrequency ablation of those levels. Insurance usually requires that we do 2 of these, at least for the first time, and then if patients get an ablation and get relief, they can just come back for ablations after that point. So the way an ablation works, no scalpels or anything involved. Basically, it's a special type of needle with a tip that will heat up and cause a lesion over the area where anatomically the medial branch lies. And that procedure is very similar in technique to the medial branch, but we do a neurocheck where we make sure that the they don't get any stimulation down the leg, that we're not too close to the nerve root before we do it. Usually that'll take a couple weeks to work. So as opposed to the medial branch block that works pretty quickly because it's local anesthetic, the breakdown of the medial branch can take several weeks. So you'll have patients call a few days later and say, it didn't work. You got to be patient. And again, it's not an immediate decrease in your pain. It's kind of a stepwise, slow improvement in your pain. This is the referral patterns. You can have this facetogenic pain in your neck as well. A lot of times patients will say that they have pain in their shoulder. That can sometimes come from their neck. They also can say they have occipital headaches, which also can come from the higher cervical vertebrae. And then in the low back, you can have pain that radiates down that you may get confused with sciatica or radiculopathy. That's where an MRI comes into play. And then sometimes, some of these procedures we do are not just therapeutic, they're diagnostic. Sometimes it is a process of elimination. Let's try an epidural. If that doesn't work, you may have facet pain. The other big injection we do is the sacroiliac joint injection. Again, similar referral pattern here. Doesn't radiate past the knee commonly, and is below the belt line and kind of in the bottom off to one side. Sometimes people have it bilaterally. Another form of arthritis. One of the big guns we have is the spinal cord stimulator. This is usually something that's reserved as one of the last lines of pain control, even after back surgery. So the most common patients that we implant these in are patients with what we call post-laminectomy syndrome, previously called failed back syndrome, although that term has fallen out of favor. We can also use it for radiculopathy that has not responded to physical therapy, medications, or other types of injections, and complex regional pain syndrome. This is a condition that usually is after a orthopedic injury, is associated with a nerve injury, where patients actually have trophic changes to their legs. That sometimes they can get atrophy, they can lose, and also their upper extremities. Muscle atrophy, temperature differences between extremities, nail bed differences, and this is another indication for spinal cord stimulation. Recently, this slide is not the most up to date. We are now implanting, there's FDA approval now for painful diabetic peripheral neuropathy. So patients that do not respond to other modalities for the painful peripheral neuropathy may be a candidate for spinal cord stimulation. For those, especially diabetic patients, you want to make sure their diabetes is well controlled, because obviously we're implanting a device in this scenario, and we want to make sure that they're going to heal and not have any complications associated with it. There is good level 1 evidence to support its use, particularly in post-laminectomy syndrome. We know that it does change the neurotransmitter milieu in the spinal cord, so a good tool to use when necessary. Obviously, any bleeding disorders, anticoagulation, we talked about poorly controlled diabetes, any active infections or antibiotic use would be contraindications to certain interventions. For more superficial injections, it's more of a risk-benefit analysis with those. So opiates. Obviously, opiates have been around for 10,000 years, and even today they are the main pain management modality. Great for short-term use, great for acute pain, not great for long-term use or chronic pain, and they're really the last resort. Now, that's not to say that there isn't a place for them, particularly in elderly folks and especially in patients with cancer, especially patients with a bad prognosis. The thinking changes. So obviously there's a lot of negative aspects of opiates. The big one we think about is respiratory depression, also urinary retention, and changes to neurologic status, ileus and constipation. Opiate-induced hyperalgesia is something we'll commonly see in patients with long-term opiate use, and immunosuppression, effects to the hypogonadism is another big thing with chronic opiates. So with the opiate-induced hyperalgesia, we'll kind of come to that here. Commonly, the way this works is you start a patient, they have a specific area of pain that's bothering them. You start them on an opiate, they're on it, they get relief. Then they develop a tolerance. Historically, not nowadays as much, but historically those patients were then increased. They got benefit, and then this pattern went on to the point where this pain that started, say, in their shoulder is now all over their body. And they tell you that, I ache everywhere. And they think that the only thing that is going to make that better is actually the thing that's causing the pain. So we do know that opiates taken for prolonged periods of time can affect the architecture in your spine and basically lower your pain tolerance. So a lot of times you have to have a conversation with these patients, say, listen, I know this sounds counterintuitive, but the thing that's going to make your pain better is if we decrease your opiate medication, not increase it. So I think that Dr. Denham will talk about this as well, but some of the things we do with patients on opiates, obviously we want to do, the state requires that we get urine drug screens periodically. It's important to remember that in most patients we want a negative urine drug screen. And patients that are on opiate therapy, we want to make sure they have an appropriate urine drug screen, so they are testing positive for the oxycodone or whatever it is they're taking. Some clinics do pill counts. That is debatable whether that should be something that should be routine or not. Definitely in patients that have red flags or that you're concerned may be diverting or misusing their medication, this is something that you have the right to do and ask them to bring in their pills. Always look at the opiate database, confirm but verify, as Ronald, or trust but verify, as Ronald Reagan always said, and use opiate risk stratification tools. So the 5 A's of opiate management: activity is probably the most important. So you want to make sure that what you're doing is having an impact on their functionality as well as analgesia. You want to make sure that these medications are not causing more harm than good in terms of opiate-induced hyperalgesia or the common ones of constipation, nausea, vomiting. You want to make sure that you're looking for the aberrant behavior, the red flags, things that seem suspicious, people that may be in the house that may be, you don't necessarily always have to be worried about the patient. If they have a delinquent teenager in the house that may be taking their medicines, that's something that you have to consider when you prescribe this medication. And effect, is it having a beneficial effect on their mood or a detrimental effect? It's important to make a distinction between pain management and addiction. We're not addiction experts. We do deal with addiction, obviously, but there are other fellowship-trained addiction specialists that some of these patients may need to see. And addicts can have pain, and that is a difficult pain population to treat, but there are modalities for them as well. So we discussed the opioid risk tool, very important in trying to identify who are going to be good candidates for opiate therapy. Another useful screening tool is the RioSword. This was developed by the VA, in particular for patients that are on high morphine equivalents. It's something to consider when you are determining whether a patient needs a prescription to naloxone. Now, naloxone is now becoming over-the-counter, so less of an issue here. But if you want to advocate for your patients to go up and get that medication, this is a way of determining whether they are at an increased risk for respiratory depression. This is also something that you can use to determine whether you want to prescribe somebody an opiate, because it talks about the risk factors for respiratory depression: COPD, sleep apnea, chronic kidney disease, bipolar. All these things, these patients are going to have a higher likelihood of developing respiratory depression, so maybe something to consider prior to starting patients on these medications. So opiates, they work both peripherally and centrally. Peripherally, they decrease neurotransmitter release. Centrally, they moderate afferent input to the C fibers in the dorsal horn and the substantia gelatinosa. This is another area, if anybody here is involved on the inpatient side in terms of identifying ways to decrease the amount of opiates that are prescribed at discharge from a hospital and during their inpatient stay. There's some examples listed there. It's basically trying to set up a system where there's more identification of issues, things like having cutoffs or caps on the quantity of medicine that is pre-filled when people are putting in a prescription. Education is a big component of that. So something else we do to try to cut down on opiates. And then the weaning considerations. Dr. Denham's definitely going to talk about this. I'll give you my 2 cents. I worked up in the Southwest Virginia area for a while, so had to deal with a lot of weaning. It's important to set expectations early. This medicine is not in your best interest at this dose. We are going to decrease it. I'm not going to make you sick, but we're going to come down slowly. It's okay to stop the taper for a little while, especially if they're having issues with it, and say, we'll stop, we'll let you get used to this level, and then we will continue on. But really sticking to that taper and not re-escalating is important. So in conclusion, be mindful of the CDC guidelines, be mindful of the state regulations on this, which Dr. Denham will talk about. Function is more important than a pain score. Obviously, we want patients to have a good pain score, but not at the detriment of functionality. Opiates have a place in pain management, but they should be used as a last resort. And when in doubt, consider a referral to a pain management clinic. Make sure you do your research on the pain management clinics. There's a lot of clinics that are not board certified, so there are 2 boards that people can get a medical directorship of a pain clinic. One is not as stringent as the others, so I would encourage you to send them to the appropriate board certified pain specialists. And if they're not having motor complaints or issues that are concerning for something that needs surgery, I would also consider sending them to pain management first as opposed to neurosurgery, because we can ultimately send them to neurosurgery if necessary as well. These are my references. I'll take questions at the end with Dr. Denham. I guess we're going to take a little break. Or do you want to go? Okay.
Our next speaker is Hannah Denham, PharmD. She's a board-certified clinical pharmacotherapy specialist with practice sites at the University Center for Pain Management of Knoxville and University Health Network UT Primary Care. Dr. Denham received her Doctor of Pharmacy degree from the University of Tennessee Health Science Center College of Pharmacy in Knoxville, Tennessee. She pursued postgraduate training as a PGY1 and PGY2 pharmacotherapy resident at the University of Tennessee Medical Center. Her current interests include acute and chronic pain management, transitions of care, substance use disorder, adult medicine, and academia. Please welcome Dr. Denham.
All right. Where I can see this. Okay, thank you for that. Yes, I am Hannah Denham. I'm a pharmacist. I work alongside Dr. Soya in the pain management clinic over at UT, and then I'm also within University Health Network, so I split my time between pain management and primary care. I am very interested in opioid stewardship, so I'm very excited to talk with you guys today about opioid prescribing and best practices, really thinking about the laws that we have in place. I have nothing to disclose. So really today I'm going to spend a bulk of our time talking about the updated CDC guidelines. How many of you have read the CDC guidelines? A few, okay. But it seems like we've got a lot of you in here that this may be the first time you're getting to review these, so that's great. And then I'm going to spend the last little bit talking about Tennessee Together, which I'm sure all of you have seen over the years, but going to give you some reminders for implementing that into your practice. So let's first start with the 2022 CDC practice guideline update. So as you remember, in 2016, the CDC came out with some guidelines that really hurt a lot of the population that was already using opioids. So they went back to this updated voluntary guideline and implemented these or added some updates to this. So there's 12 evidence-based recommendations, and they are specifically for clinicians who prescribe opioids for outpatients over the age of 18 years of age with acute pain, subacute pain, and chronic pain. Now, there's a slew of prescribers that it is meant for, and you'll notice what's not on here is your pain specialist. And that's really just because they're already implementing and using a lot of these tools that are within the CDC guidelines. But you can see many of you, I'm sure, are within this scope here. So these are the 4 key areas that I've broken my presentation down into. So they talk about determining whether or not to initiate opioids, how to select opioids and their appropriate dosing, deciding that duration of initial opioid prescription and conducting follow-up, and then assessing risk and addressing potential harms of opioid use. I've put little numbers there because at the very end of your slides, there's the actual full component of what's in the CDC guideline itself. So here's recommendation 1 and 2, which talks about determining whether or not to initiate opioids. So some overall general considerations for the initiation of opioid medication. So what type of pain does your patient have? It needs to be appropriately assessed and treated independent of whether or not you're going to prescribe opioids. So this is kind of going back to what Dr. Sawyer was talking about, is have you considered that multimodal and multidisciplinary approach? It's super critical that that's happened. Are they going to physical therapy? Have you considered sending them to a pain specialist? What are these things that we need to consider before initiating opioids? And then it's, of course, really important, your role as clinicians, to ensure that access to patients is available, whether that be non-pharmacologic or pharmacologic therapies, as you see appropriate. So again, have you given them the chance to go to physical therapy? Have you given them the option to maybe go to a psychiatrist or behavioral health? Have they gone to pain management? So let's first look at acute pain, because we know that opioids do have a place, and a lot of times that is within acute pain. So first, of course, non-opioid therapies are at least as effective as opioids for treating low back pain, neck pain, certain musculoskeletal injuries, dental pain, kidney stone pain, and headaches. So really maximizing your NSAIDs, your acetaminophen, your gabapentinoids, all these non-opioid pharmacologic therapies that we have, before going to opioids. Make sure the patient's included in that risk-benefit discussion of whether or not opioids should be initiated. Do they really, truly understand what's going on with this opioid epidemic? Do they recognize that they may be at risk for those more harmful events with opioid therapy? And then making sure that if opioids are warranted, we're starting with immediate release at the lowest effective dose for patients to take for that duration that you suspect they need for those pain complaints. This is going to be the same strategy for both your patients acutely or with chronic pain. So then when we talk about determining whether or not to initiate opioids for subacute or chronic pain, again, non-opioid, non-pharmacologic therapies are in most cases preferred. That doesn't mean that patients need to have failed these therapies prior to starting opioid therapies. And that's kind of where you see insurance companies and other things trying to limit you. It's not that this needs to be a must, but it certainly needs to be a consideration before jumping to opioid therapy. Circumstances where the provider-patient agreement may lend to opioids. So there are a lot of times if they're, hospice care, things like that, palliative care, that they may definitely need opioids. And then these other times, so serious illness with a poor prognosis, so hospice or palliative care. And even if it's not going that route and maybe the patient doesn't have the potential to return back to their full level of function, that may be a time where you consider opioid therapy. If they just, for some reason, have a contraindication to all other therapies, albeit very, very low possibility of that, but if they do, and then again, if overall goal is patient comfort. So again, making sure that the risk benefit with the patient is clear and that goals of treatment are clear. So as Dr. Soya alluded to, what are their functional goals? Are they able to go back to playing with their grandkids, or can they go to the grocery store? What are those specific things that you're going to measure when you've started them on opioid therapy that in 1 month, 2 months, 3 months time, they're able to come back to you and say, I'm able to do X, Y, and Z because I've started this therapy. And then do not start opioids without an exit strategy. Make sure that the patient knows that these goals are going to be discussed over and over because what you don't want is to start them on these therapies and they end up on them forever with absolutely no goals in mind. So then what about continuing opioids? So if you've had this patient on opioids for more than 30 days, have you considered the reversible cause of the chronic pain, or has it been reassessed? So again, continuing opioid therapy at this point can lead to long-term therapy just simply because those medications haven't been reassessed. So was your patient recently in the hospital with an acute pain complaint? They come to you, you just continue the opioid, but in a month's time, are you reassessing that pain complaint because those opioids are just still on board? Are they a new patient to you and they're on opioids, but you're continuing them because they've asked instead of continuing them and reestablishing or reassessing that pain complaint? So again, that's kind of the second bullet. New patients that are already receiving opioids should reestablish treatment goals, including those functional goals. Again, taking your time to discuss the risk-benefit of continuing opioids and educating your patients. And then we also have to consider patient access to medications. So when opioids are necessary, things are still expensive, especially some of our safer options when it comes to opioids, if you will. So things like buprenorphine that are a little bit safer end up being a lot more expensive for your patient. So we do still have to consider some low-cost options when it comes to opioid therapy. So here's just a short, albeit not all-inclusive, list of immediate release and extended release options. So you can see the 3 different columns there, the middle being ones that have the option of both immediate and extended release. They talk about opioid tolerance a lot within the CDC guidelines, and really what that's defined as is 60 morphine milligram equivalents per day for at least 7 days. So once your patient has reached that 7-day mark, if they are on this many morphine milligram equivalents per day, they are considered opioid tolerant. Make sure that if you do switch from an immediate release to an extended release, that you consider incomplete opioid cross tolerance, so making sure you're reducing that total daily dosage. Usually a good rule of thumb is 10 to 20%, depending on your patient. And then avoiding the extended release and long-acting in your patients with comorbidities, such as end-stage renal disease, hepatic dysfunction, respiratory disease, sleep apnea, and or your elderly patients. So now we get into the next set of recommendations, which talks about selecting opioids and determining dosages. So determining dosages, again, throughout the CDC guidelines, they talk about this, but this is intended to be a guidepost, not a restriction, to help facilitate your decision making. Again, this is kind of where our insurance companies and other laws went wrong with the 2016 guidelines, really making it more of a law than a guidepost. And so they really wanted to point that out and clarify the language within the 2022 guidelines when talking about this being more of a help and guidance to you, just like any other guideline really. So when we think about your opioid naive patients, again, the lowest effective dose based on other comorbidities, and then thinking about starting it with just a single dose of 5 to 10 MMEs or 20 to 30 MMEs per day. For your chronic opioid users, again, dose changes should generally be avoided following that acute pain complaint. So if you've got a patient that you see regularly that has chronic pain, now they've been in a car accident or something, has had a minor surgery or some sort of surgery that's required opioids, really making sure that there's a plan in place before, if possible, or at least at the time of that acute pain complaint wrapping up, that they're not going to end up on this higher dose of opioids long term. It's just for that short period of time that they may need a little bump to get through that acute pain complaint. And then again, always assessing that risk benefit when patients are utilizing over 50 MMEs per day. So if you reach that point where they're over 50 MMEs per day, reassessing the patient to ensure that benefit is still seen. So here's an example of dosing strategies. Again, this is always as needed. Never, ever should you see a scheduled immediate release medication in your patients. Will they be taking them scheduled? Most likely. Should you prescribe it and encourage it that way? Absolutely not. So example dosing strategy, if you think about what we said with maybe the 20 to 25 morphine milligram equivalents per day, that's going to be the lower side of your dosing for those patients that have a higher risk of some of those harmful side effects like respiratory depression, falls, et cetera. So starting there if they are at risk for those, versus your 30 MMEs per day for your otherwise healthy adult. I've got some examples down there at the bottom, and then towards the end of this, when we talk about Tennessee Together, I'll give you a lot more examples so that you don't have to worry about what's MME is this and that. So, but there's a few examples there at the bottom. So now we'll talk about duration and initial opioid prescription and follow-ups. This is recommendation 6 and 7. So how long should we continue opioids and follow up with these patients that have acute or subacute pain? So as Dr. Soya mentioned earlier, you don't want to prescribe any greater quantity than needed for the expected duration of pain severe enough to require opioids. Now in Tennessee, with our Tennessee Together laws, they make it a little bit easy to follow this recommendation because you can't tend to prescribe over a certain amount of MMEs at a time in these acute pain complaints, but still really keeping this in mind regardless of that law. So avoid prescribing additional opioids just in case. Set up a time to reevaluate the patient and prescribe more at that time if needed. So if you're able to conduct a preoperative evaluation prior to a procedure, excellent. This will give you the chance to talk with the patient about how much pain you expect them to be in, establishing those treatment goals post procedure, and making sure that they've already have follow-up planned so that you're only giving them the exact amount of medication that you suspect they'll need, with a plan for them to know that if they're still in pain, they're going to be seeing you to where you can assess that and re-prescribe if needed. Follow-up should occur within 1 to 4 weeks of starting or increasing therapy depending on the medication and dosage. So the risk of overdose is increased within the first 2 weeks of treatment or when the total daily dose is over 50 MMEs per day. That's a very high risk. So really important to keep that in mind. And then considering doing initial follow-up closer to 4 weeks for patients with immediate release opioids or when their dosage is less than 50 MMEs per day. So what about for chronic pain? So again, reevaluating the benefits and risks of opioids before starting therapy for subacute or chronic pain or any type of dosage escalation. Keep your patients part of the conversation. Don't just rely on the patient saying they're having increased pain complaints. Get to the root of it. Determine if the patient is taking their Tylenol along with the medication, or what is the cause of the pain. Have you reassessed their need for physical therapy, for a pain specialist, things like that, keeping them aware that there are other options than just increasing their pain medication. And then patients continuing long-term opioid therapy follow-up is recommended every 2 to 3 months. So again, remember how much higher the risk of overdose is when they are now above 50 MMEs per day. So you may want to do follow-up a little bit closer if you do increase opioids past that. So thinking closer to the 2 months for those with increased risk of opioid use disorder, and then maybe even a shorter follow-up for medications that have a pretty variable duration, such as methadone. All right, so now we're going to talk a good bit about tapering. This is where the 2022 guidelines really impacted their changes or made the most changes. So when do we taper? A lot of this I think is pretty obvious, but want to make sure that we still are all aware that this is now within the guidance. So patient has been treated for a prolonged period, years, and the benefit or risk balance is unclear. So have they grown a tolerance? Are they having higher dosing now without evidence of benefit? Again, a lot of times we see that we've inherited these patients who are already on high-dose opioids, and maybe we haven't reestablished the risk-benefit for these medications, and they've just continued on them for years. Is there evidence of opioid misuse? So are we having problems with urine drug screening? Is there CSMD or prescription drug monitoring showing up inconsistent? Things like that. Are they having, pill counts that aren't correct? Has the patient had an overdose or other sort of serious event that causes hospitalization or injury? So, if you're a patient on opioids and all of a sudden they're in a motor vehicle accident or they've had a fall, things like that, assessing that change. Are they now receiving another CNS depressant? Have they had some sort of trauma that's now caused them to be on a benzo or something to help with their mood? Really assessing the need to continue that dual therapy together. Do they have a new diagnosis or a medical condition that puts them at higher risk? So we've talked a lot about sleep apnea because of your greater risk for respiratory depression or liver disease or kidney disease that can cause your patient to accumulate more of that medication. Is the patient requesting a dose reduction or they want to stop the medication? We see that fairly often. The patient says, I just don't want to be on much medication anymore. And so we try to start the tapering process with them. Maybe their pain's improved. Maybe they've reached their functional goals. They're ready to continue getting maybe their interventional therapy and feel no need to stay on medications. Those are our favorite, and that's the time to really consider tapering opioids. And then kind of lastly, opioid therapy has not been meaningfully able to reduce their pain or improve their function. So you've assessed at that 1 or 3 month mark that they're just not getting any improvement. So why continue a medication that can really only cause harm rather than be helpful? Some other things to consider. Are they on multiple respiratory depressant medications? I kind of alluded to this with the use of benzodiazepines. Of course, we know that gabapentinoids have a black box warning for using these together, so considering that as well. Not necessarily avoided at that point, given it is a black box warning, but really making sure that the dosing of these medications, if you're going to use them together, is at an appropriate and safe dose for your patient. Do they have non-opioid therapies available? So are we appropriately using multimodal agents? Do they have mental health comorbidities? Similar to what we talked about with the REASSORD score, assessing for bipolar, ADD, things like that can put them at higher risk for having complications with opioid therapy. And then, does your patient have an undiagnosed opioid use disorder? So as we mentioned earlier, there's, of course, a big difference between pain medicine and addiction medicine, but a lot of times your patients with pain may also have opioid use disorder or vice versa. So really considering that when it's time to taper. So I've got some examples here on how to taper. This is probably one of the most often things as a pharmacist that we get asked to help with. So here's an example with acute or subacute pain. So this patient to be tapered off oxycodone 5 milligrams 4 times a day is needed that they started 8 weeks ago. The patient reports taking all 4 doses per day. After a long discussion of risk-benefit of continuing opioid therapy, you both agree it is time to begin tapering therapy. So despite the education you provide to your patient, they're still very nervous to come off the oxycodone, so you begin a slow taper. So the rule of thumb here and what the CDC guidelines really push for is to decrease by 10% of the original dose per week until approximately 30% of the original dose is reached. I know you guys really want to do math right now during the day, but here I've laid it out for you. So that total daily dose being 20 milligrams. So if you decrease by 10%, that original dose per week comes down to really decreasing by 2 milligrams per week every 3 weeks. Now this gets complicated because medications don't come in the doses in which we want for this, but you can round to the best you can, and really making sure that you involve your pharmacist or where they're going to fill their medication and make them aware that this is what you're doing, because if they do get prescriptions for 2 separate opioid dosages, it can be complicated and a little bit messy when it comes to insurance companies, but a lot of these plans, you're able to half a tablet and still provide your patient with the necessary medication. So if you look down towards the right there, your 5 milligrams and 2.5, that's a tablet they can split. So just really making sure that you give your patient the appropriate directions and involve their care team that this is the plan for tapering. So now we have another patient that has acute or subacute pain. So your patient is following up in clinic for the 3rd follow-up since surgery. They've been prescribed oxycodone 4 times a day as needed, and they started 12 weeks ago. Patient reports they're only taking 2 tablets per day. However, on investigation of their CSMD, you discover inappropriate fill dates. So after discussion of the reported history versus the fill history, the patient admits that on some days they'll take 4 to 6 tablets. So you have concerns that the patient may be misusing their medication. You decide to do another full workup of the source of pain and begin discussion of opioid taper. Because the patient is already taking less tablets on some days than others, you feel a quicker taper is appropriate. So now, again, their dosaging is the same. You're going to decrease by 10% of the original dose per week, but now you're able to decrease by 2 milligrams per week for 3 weeks. And then you can kind of see down there at the bottom, you're going just from twice a day down to once a day, and then you're able to stop. And then lastly, with chronic pain, this is, of course, when it is the most tricky. Your patient has been on therapy for 7 years, and they're following up in clinic today. They've been on opioid therapy since their back surgery 2 years ago. You note on their functional assessment that they're back to the same level of activity as they were prior to surgery. Additionally, they tell you they graduated from physical therapy 3 months ago. You begin the discussion of discontinuing opioid therapy. So as Dr. Soya alluded to earlier, the success rate of tapering is higher and much better tolerated in patients who are given a slow taper after being on therapy for over a year. So now you're decreasing by 10%, but you're going per month or slower rather than per week. If you go any faster than that, you risk your patient being really uncomfortable and not wanting to continue the taper. It's not going to kill them to go through withdrawal, but it's going to really probably upset them and make them lose a little bit of trust in you with trying to take them off this medication. And oftentimes patients are really terrified of withdrawal, so the slower we can go and the more comfortable we can make them, the more likely we are to be successful in that taper. If you're getting more towards the end of that taper, you're able to taper a little bit more rapidly from up to about 20% if needed. And then, of course, if there's any concern for opioid dependence at that point, making sure you refer them appropriately to addiction medicine. So what's the practicality of this? I've already mentioned this, the patient able to split their tablets. Does the patient need to given a certain prescription that allows them what may seem like less or more tablets, so they're able to split that? And again, involving their care team to let them know this is why you're writing the prescription this way, or as maybe giving the patient a piece of paper that gives them the exact directions that may have to differ in order for these medications to get coverage. Does the patient need to be first converted to an IR formulation before tapering? You don't want to taper them when they're on an extended release. You want to take them from their extended release to their immediate release and then begin the taper process from that. Again, pharmacy limitations we've already discussed. If the patient is eager to discontinue or they're experiencing undesirable side effects, you can taper more quickly. Just make sure that the patient's tolerating that and has appropriate follow-up. So if you can't see them in your clinic, maybe yourself or a nurse or someone can call them 2 to 3 days into that taper and make sure that they're doing okay and they feel like they have someone they can reach out to if they feel uncomfortable. And then manage withdrawal symptoms as appropriate. A lot of times you may consider giving them clonidine or things like that in order to help with some of those side effects with potential withdrawal. All right, the last bit of this is assessing risk and mitigating potential harm. So this is your last 5 recommendations, 8 through 12, naloxone. So while we do have the Reassured that helps you decide if your patient needs naloxone, at this point, if you're going to prescribe opioids, it is best practice to offer every single patient naloxone, whether they hit that score on Reassured or not. I prefer to educate patients in clinic on the importance of keeping naloxone on hand. You can defer that to their pharmacy, but I think it really means a lot to hear from their provider why this naloxone is important. A lot of times having to say, do you have grandkids in the home? Do you have pets that may knock it off the counter that someone else can then get to? That really seems to speak to them as far as their willingness to pick up this medication. And then prescribetoprevent.org is a really good resource to send your patients to or for yourself if you have more questions about naloxone. These are the available versions of naloxone. You'll mostly see that generic nasal spray there to the left. And so in July of 2022, naloxone access was increased across the state of Tennessee, which was excellent. But then as we know, it's now going to be over the counter as early as late summer. Some concerns with that could still be cost. So it may still be important for you to send that prescription for your patient because insurance is likely to cover it versus if they're having to get it themselves over the counter, that may be a barrier for them to receive it. So these again are just your formulations. You can see that those first two nasal sprays are the 0.4 per 0.1 ml. So they come as a 2-pack. So your patient will spray into one nostril and then repeat that second dose into the other nostril about 2 to 3 minutes after if there's no response or a minimal response. That Cloxato on the end is not normally covered by insurance, but is another option. It's just a slightly different formulation of the product. Cost-wise, your generic is going to be the one that's often covered, just as we would suspect. Here's your PDMP, your prescription drug monitoring program. So it is recommended to review this before initial opioid prescription and then every 3 months or more frequently. Again, consider how this is going to be applied in your practice. There is no true risk score that's been validated to help with PDMP, but knowing how you're going to use it in your practice and discuss these findings with your patient is really important because a lot of times you can find things that you don't expect to find. So making sure that you have those conversations if that does occur. And so kind of keeping in mind too that this doesn't just show you opioids, it shows you all controlled substances. So if they've had a recent procedure, MRI, maybe that they've had a benzodiazepine and you see maybe one tablet on there versus if they're getting long-term benzodiazepine therapy, those are things that you can nail out here. But of course, as we know, trust but verify, because a lot of times you will see that the last couple of weeks may not show up. So if the patient is saying or you think they have a prescription for something, it may not be reported yet. And again, discuss the information found in the PDMP with your patients. Toxicology testing, so this is your urine drug screening. This should be done prior to initiating opioids and then at least annually during opioid therapy. So again, wanting to assess for therapy that is prescribed and therapy that's not prescribed. So again, making sure those illicit substances are looked for as well as prescribed medications that they could potentially be on. And then again, having that open dialogue with your patients about the expected results and how you intend to use these. I think a lot of patients can feel criminalized when you're wanting to do a urine drug screen, but just helping them understand that this is really to improve their safety. It may not be because you're looking for illicit substances, but it could very well tell you that they're on something prescribed that you're not aware of that's still in their system or could be harmful for them. And then, of course, having a plan in place if you get results that you're not expecting. Concomitant prescribing, this is most challenging with your elderly patients. So in patients receiving opioids and benzodiazepines long-term, you need to carefully weigh those benefits and risks of continuing therapy. So again, discuss that with the patient and their care team. In some situations, you're going to see patients that are going to be on benzodiazepines and they're beneficial and they're necessary. So this would really be a time to really make sure that if opioid therapy is necessary, are we really truly on the lowest effective dose? Because, of course, combining these together really increases that risk of respiratory depression and falls. If they are on benzodiazepines and you need to start an opioid medication or prefer to start an opioid medication, do not discontinue their benzos abruptly. We all know that that can cause seizures and unwanted side effects. So making sure that we don't just discontinue those because the patient has this pain complaint and we want to start opioid therapy. Other things to consider beyond benzodiazepines are your other CNS depressants. These are often medications that we see in our pain clinic, but oftentimes are also in your primary care clinics. So gabapentinoids, muscle relaxants, and then non-benzodiazepine sedatives like zolpidem. Your patients with opioid use disorder, again, there's definitely a difference between pain medicine and addiction medicine, but there's times where you might be the first ones that are recognizing their opioid use disorder because you're prescribing their opioid therapy. So of course, detoxification on its own is not recommended. So there definitely needs to be that conversation because there are increased risks of resuming drug use if it's stopped abruptly. If opioid use disorder is suspected and you're prescribing opioids, make sure that they are referred to the correct place in order to get the care that they need. There has been medication treatment of OUD that's been associated with reduced risk for overdose and overall deaths, as we are aware. So that recognition is an opportunity for you to potentially put in life-saving measures. And then, of course, as mentioned, identify what your treatment resources are for these patients that may have opioid use disorder. I couldn't do this presentation without talking about the 2023 Consolidation Appropriations Act, which is going into effect in just a couple of weeks. As you are well aware, the X-waiver registration is no longer required to prescribe buprenorphine for opioid use disorder. So it only requires a standard DEA registration number that includes Schedule 3 prescribing authority. So limits or patient caps were eliminated on the number of patients a prescriber can treat for opioid use disorder with buprenorphine. It does not impact applicable state laws or regulations as of yet. And then, of course, as I mentioned, the new training goes into effect in just a few weeks. So now we'll talk briefly about Tennessee Together and really what that looks like for prescribing. I'm sure at this point, if any of you prescribe opioids, you're well aware, but I think it's an important reminder of what our state requires. So I include this in here as a reminder to you because I feel as a pharmacist, it's important for my colleagues on the outpatient side or community side that they also have a corresponding responsibility. So as annoying as it can be to get prior authorizations or someone to kind of feel like they're putting a hindrance on you prescribing, just remember that they're written into this law as well. So the responsibility for the proper prescribing and dispensing of controlled substances is upon the prescribing practitioner, but a corresponding responsibility rests with the pharmacist who fills the prescription. So I plug that in just as a little reminder for your community pharmacists that may be reaching out to you. So what is Tennessee Together? It's our Tennessee opioid laws that went into effect July 1st of 2018. The goal was to target the state's opioid epidemic through prevention, treatment, and law enforcement. So it decreased supply and dosages of prescription opioids. It put initial opioid limits. It made prescription requirements. It did allow for partial fills of controlled or of C2 opioids. And there were new reporting requirements for the CSMD. There has always been a max of 30 days per prescription of opioids since 2013, so that was not new with the 2018 Tennessee Together. So I put this little picture together just kind of to wrap up what Tennessee Together opioid laws are. So it told us about the CSMD checks. So pharmacists or other delegates as well as prescribers must check the CSMD for opioids and benzodiazepines prescribed for human patients at initial dispensing and every 6 months while therapy is active. It's required the ICD-10 codes, so they must only be written on opioid prescriptions for human patients for more than 3 days and or more than 180 MMEs. This did allow for partial fills, so opioid prescriptions for more than 3 days, they're not required to be partially filled, but they're still allowed to be partially filled if requested by the patient or the physician. So at one point, it was a requirement that they could only be partially filled, but now it's an option for you or your patient to fill just partial of that. The 3-day or cough exception, so there's no additional prescribing or dispensing requirements. So CSMD checks for opioid prescriptions written for up to 3 days. However, I still highly encourage, even if you're only writing for 3 days, to check the CSMD. And no more than 180 MMEs or prescriptions for cough, so things that have codeine in it for cough are not required for any of this. This gave us our MME and day supply limits. So there's a general limit up to 10 days and 500 MMEs. For surgery, up to 30 days and 1,200 MMEs, and then medical necessity, up to 30 days and 1,200 MMEs. And then you've got all of these reasons that your patients could be exempt. Are they active or palliative, hospice or palliative care, sickle cell disease? Are they within a licensed healthcare facility? Do they have chronic pain? Are they on medications for medication-assisted treatment rather than for pain management? So this, again, just breaks it down a little bit differently. So there are no requirements before prescribing if it's up to a 3-day opioid prescription and less than 180 MME total dosage. And then you've got requirements before prescribing to check the CSMD, do a thorough patient evaluation, document consideration of alternative therapies, and why an opioid was used. Again, this kind of came from that issue in the 2016 CDC guidelines where they were saying you need to try X, Y, and Z before you can go to opioids. So I suspect some of this could alter over the next few years from a documentation and alternative standpoint. But that's going to be more towards our insurance companies than anything else. So obtaining informed consent and including the ICD-10 code on the chart in the prescription. So I break this down a little bit further into the next few slides. Again, this is just a little bit larger of who is exempted for these laws. So just a little cheat sheet that I think is really helpful when it comes to, do I need to put an ICD-10 code? Do I need to do additional things to prescribe this opioid medication? So again, if it's up to a 3-day prescription, less than 100 MMEs total, nothing else is needed. So I've given some examples here. We don't really prescribe codeine much. I think in the dental world, maybe it's still used quite a bit, Tylenol number 3. So kind of showing you that your maximum for that would be 40 tablets to not have to do an additional documentation on the prescription. However, 40 tablets of Tylenol number 3 within 3 days is a feat for a patient. So wouldn't necessarily recommend that, but just kind of painting that picture for you that that is technically the maximum amount of tablets. And you can see 36 tablets of tramadol, 18 of hydrocodone, 12 of oxycodone or Percocet, and then morphine would also be 12 of the 15 milligram tablets. What about for your patients with up to 10 days or 500 MMEs? This is where an ICD-10 code is required. So whether that be for surgery or chronic pain, things like that, an ICD-10 code is required on this prescription. So again, I have some recommendations here. The up to 10 days, meeting 500 MMEs would be 100 tablets of 50 milligram tramadol, 50 tablets of the 10 milligram hydrocodone, 33 tablets of oxycodone or Percocet, and then 12, again, of the morphine tablets. So now you get to surgery. They're allowed a little bit higher days. You still have to actually write surgery on there and have the concomitant ICD-10 code. This allows up to 1,200 MME total daily dosage. And on the flip side, you also have your up to 30 days medical necessity that needs to say the ICD-10 code and also include medical necessity. So what does that look like here? Now we're getting to the 30 days, so you're seeing your higher number of tablets. So, hydrocodone 4 times a day with 120 tablets, oxycodone or Percocet being 80 tablets of the 10 milligrams, and your morphine also being 80 tablets of the 15 milligram tablets. And then exempt, so this is often the patients that we are seeing in the chronic pain clinic. There's not a maximum amount of drug that can be prescribed at this point, but an ICD-10 code is required, and the word exempt is required to be printed on that prescription as well. So in summary, the CDC guideline is a set of recommendations to really consider implementing within everyday practice. Again, it's a guidepost. It's not a requirement, but it really does set forth a lot of helpful recommendations when considering opioid therapy and how to manage that opioid therapy. Prescribing opioids is complex. Patients have a lot of comorbidities that can interact with opioid therapy, and so really finding them the right place. Have you reached out to your pain management specialist for other ways to manage their pain before going the opioid therapy route? we kind of mentioned this earlier, a lot of times we're seeing patients that are already on opioid therapy that probably could have benefited from a specialist much earlier than that opioid therapy. And then when opioids have a place in therapy, it's our role to ensure that they're used appropriately, safely, and with a plan for discontinuation when applicable. This is the recommendation categories and evidence types for your reference. And with that, I think we'll take any questions that you have.
Any questions?
You know, a lot of times you'll have some patients that have elderly, have a lot of comorbidities, and you see a lot of knee pain. There have been some discussion about doing genicular blocks. Do you do that, and how do you decide to do that, and what's your experience with it?
So yes, we do that. Sometimes we'll do that for really significant osteoarthritis in patients that aren't great candidates for surgery, especially the elderly who aren't going to get much benefit out of it and have risk factors specific for surgery. And then sometimes we'll do it for people that have had knee replacements and have pain afterwards. It has varying degrees of benefit. There is some thought, we target 3 genicular nerves, but there's some thought that there's more innervation than that. But it's definitely a treatment option, especially if it's that or starting opiate therapy. It would be definitely something to consider. It's like what we discussed with the medial branches. We do a diagnostic block first, so we see if they're going to get benefit before we do an ablation of those genicular nerves. But yes, that is something we do.
It's a follow-up question. In terms of your physical examination, differentiating sacroiliac pain from facet pain, what sort of things do you note with your physical findings that would help differentiate that?
Yeah, great question. So the very first thing is above or below the belt line. So if somebody's pointing kind of in their buttocks area, pain both with the facet and sacroiliac can radiate into the back and into the thigh, the posterior thigh. But the maneuvers we do, so we discussed the one for facet, which is lateral rotation and extension. For the sacroiliac, there's several. The most common one's something called a Faber. I wish I had somewhere to do this for you, but basically you get them to put their affected side like this over their laying supine, and then you put pressure down, and that does create pain back there. There's also something called the Gainsland's test. There's a different one where you get them to bring their affected side up and they hang their non-affected side down, and you put pressure on this side and they'll report pain there. Those are ways to, those are provocative tests for the sacroiliac joint. I saw there was one in the back there.
I actually had 2 questions. The first one for Dr. Sola. Have you noticed an increased risk for bleeding with the caudal injections when patients are on antiplatelets?
So we would never do, so there is a risk. I have, knock on wood, never seen an issue related to that. Theoretically, you would potentially have less of a risk because you're so far down. For example, when we do a cervical epidural, we won't even let patients be on aspirin, on an anti-inflammatory, because it's such a small area. In the lumbar area, they can be on aspirin. Because the thinking is they can afford to bleed a little bit more back there, because there is some level of bleeding that's going on. But that's a non-starter for anything that's going near the conus or the cauda. Cauda equina, we stop all antiplatelet or anticoagulation.
And the next one is for Dr. Denham. You were talking about the training. You had the 8 hours of training for the DEA people. Is that just for people who are dealing with the OUDs, or is it everybody?
So it's just your overall, if you're going to be prescribing that, 8 hours of that has to be towards some sort of addiction medicine.
Only for those that are going to be prescribing those things?
Yes.
Okay.
Yeah. I mean, if you're not planning to prescribe it at all, it doesn't need to be involved in that. But instead of having to have the X waiver and special training with that, it can now count towards your just regular DEA requirements. Your training can come from those 8 hours.
Okay.
Follow up to that. So is that 8 additional hours, or as a formerly, I guess now formerly ex-waiver physician, do I need to undergo more 8-hour training that's similar to my other 8-hour training that I had to do for the ex-waiver?
That's a great question that I hadn't come across yet. I think it's just when you're up for renewal for your DEA,
Okay,
as
that
long
might
as you
cycle
have
with
that
the DEA.
training, it rolls into that.
Okay.
So there's no, from my understanding, additional like there was with ex-waiver. It is just now in order to.
Rolling.
Yes.
Thanks.
Any other questions? Okay, thank you both. Okay, thank you to all of our wonderful presenters. Now we're going to welcome Dr. Natalie Freeman. She is the Assistant Dean of Research at LMU-DCOM, who will present the winners of the poster competition before we adjourn for lunch. And in-person attendees are encouraged to join us for the poster session across the hall beginning after that. The conference sessions will resume tomorrow at 7 a.m., and we look forward to seeing you then.
Thank you all. I know you're ready for lunch, so I'll keep it quick. This is our first year doing a poster competition here. We're super excited. We had 22 students participate, so I wish I could give them all an award. Not possible, but we do have award winners here today. We'll have 5 students here presenting their posters, so feel free to walk around. We also have QR codes, so you can look at all 22 posters on your phone. We'll have a guidebook too, if you're looking for a specific title. There's computers set up with iPads. You can click on the title and look at those posters. Anyways, our winners are, first place winner is 12 weeks of dance, exercise in rural Appalachia, a patient-reported outcome measure of long-term health conditions, and that is with student doctor Megan Kusmich, Cambry Fox, Caitlin Gates, Hannah Campbell, and her faculty mentor is Dr. Lori McGrew. Megan, will you please come up? Her poster is fantastic. Thank you so much. Congratulations. Our second place winner is COVID-19 related submassive pulmonary embolism, a case report and implications for future care. It's student Dr. Brittany Kendi, third year medical student with Dr. Malcolm Foster, Beth Polk, and that is with LMU-DCOM and Tenova Healthcare Cardiovascular Research. She has won second place, and I think she is online with us today. She's in New Jersey, so she couldn't be here today, so congratulations to her as well. Our third place winner is testing St. John's wort with zebrafish to measure the anxiety and stress levels, and that is with student Dr. Sebastian Woodson and Professor Lori McGrew at LMU-DCOM. Unfortunately, Sebastian is in lovely sunny California today and said he couldn't be here today, but congratulations, Sebastian Woodson. Our final award is an award for outstanding project related to osteopathic manipulative medicine. It's the association between a somatic dysfunction and myofascial trigger points that refer pain to the head and neck. And that is with student Dr. Roderick Towner, he's a fourth year student, and Dr. Douglas Weston at LMU-DCOM. Roderick Towner, are you here today? He should be at his poster, most likely, but congratulations to him as well. I have given a special invitation to 3 other students so that they can present their work. Some of them are first years, so, well, I guess going into second year, so this provides them a great opportunity to come and talk to you guys and present their posters and networking skills. The first one will be a case study with vaginal hysterectomy of the didelphic uterus, and that's with student Dr. Madeline White and Dr. Howard Harrell with LMU-DCOM and Ballad Health. The next poster will be sickle cell disease knowledge of health care providers with student Dr. Brittany Blair, Miracle Ingram, and the faculty mentor, Mary Beth Babos, with LMU-DCOM. The next one will be Cannabis Knowledge and Opinions with student Dr. Colby Lester, and again, Dr. Mary Beth Babos at LMU-DCOM. I hope you enjoy our poster presentation. There's lunch next door. Posters will be in the hallway as well with your lunch. So have a good day. Thank you all so much for coming.